on YouTube. Okay, we're live.
Okay, thank you. So we can call the meeting to order. We can proceed with the call for the quorum.
Thank you, Chairman. I will start with our voting commissioners. Dr. Khan,
Present.
Dr. Barron,
Present.
Teresa Bohannon,
Present.
Babette Bond,
Here.
Jessica Flood,
Present.
Flo Khan. Is Flo here?
Flo will be joining us late.
Oh, okay. Dr. Peckham,
Here.
Yarleni Roa-Dugan,
Present.
Sean Shaner,
Here.
Dr. Sonam.
Dr. Sonam should be joining us momentarily soon.
Okay. Mason Van Helling.
Morning, everyone. I'm here.
Moving on to our advisory commission members, Heather Korbulik,
Present.
Barbara Richardson,
Here.
Richard Whitley.
Here.
Mr. Chairman, that concludes our roll call and we have a quorum.
Thank you. So going ahead with our agenda, the next agenda item we have is the public comment. Do we have any public comment in the north?
Bear with me. Chair Khan, let me see. So attendees, if you are watching, if you can go ahead and raise your hand to indicate that you would like to speak. If you are on the phone, I believe it's *6 or *9 to raise your hand. I've got one person.
Okay. Need to identify themselves.
Sure, Mr. Charles Duarte, you are in the meeting and you are able to speak.
Are they on mute or connected?
He's connected. Mr. Duarte, I've asked you to unmute. You are able to join us.
I apologize. Can you hear me now?
We can.
Yes.
Very good. Thank you. And good morning, Dr. Khan and members of the commission. For the record, my name is Charles Duarte, Dementia Care Director for the Alzheimer's Association in Nevada. I'd like to thank you all for the hard work that you folks have been doing during a very difficult time, not only here in Nevada, but across the nation. So thank you for the work. Our goal is to raise awareness around Alzheimer's disease and other dementias and to increase the numbers of patients and caregivers who actually receive an early diagnosis. That's so vital for people to make plans and to have their legal and financial affairs in order as they move forward with the disease. Alzheimer's disease and other dementias represent the largest hidden public health crisis, impacting more than 5 million people nationwide at a cost to the healthcare system of over $300 billion. In Nevada, there are an estimated 49,000 people living with Alzheimer's or another dementia. By 2025, that number is expected to rise to 64,000, the third fastest rate of growth in the nation. According to survey data, 1 in 6 Nevadans 45 years or older report confusion or memory loss that is worsening. Nearly half of them have not spoken with a healthcare provider, nor has a healthcare provider spoken to them about their possible diagnosis. In 2017, Nevadans with Alzheimer's disease and other dementias experienced 1,712 emergency department visits per 1,000 individuals, an increase of 34% since 2007. Dementia also accounts for more than 25% of all hospital readmissions here in Nevada. It's estimated that Nevada Medicaid will spend $203 million this year for people with Alzheimer's and other dementias, and that the cost is expected to increase by almost 37% by 2025. Equally important is the impact of the disease on families in Nevada. It's estimated there are 153,000 caregivers, unpaid caregivers in Nevada. These are spouses, children, friends, and family members who have taken time off from work to care for a loved one. It's estimated they provide 175 million hours of unpaid care at an estimated value of more than $2.2 billion. It's also estimated that 48% of residents in nursing homes have a dementia diagnosis. Most of these long-term care residents with dementia also have higher rates of multiple chronic conditions, making them vulnerable to COVID-19. Alzheimer's disease and other dementias clearly have an impact on our health system from a cost and utilization perspective, and it's expected to increase. The cost of care is not only a burden to Medicare, but also to Nevada Medicaid, which covers an estimated 60% of all long-term care costs in Nevada. This cost burden to the state has the potential to crowd out other expenditures, including vital state services such as education and public safety. Given this, I'd like to suggest that the Patient Protection Commission consider the implications of Alzheimer's disease and other dementias on our long-term care systems, as well as our medical systems, and the lives of those living with the disease or caring for someone with dementia. I'm also available to present more detailed information to the Commission as a part of a future agenda. And I'd be happy to answer any questions.
Thank you, Jack.
Okay.
Appreciate your input. So anybody else from them? Go ahead.
I don't
Somebody
see anybody else. If you want to give everyone else that's joining us, I think we had a couple of new attendees join us. Please raise your hand at this time to indicate that you'd like to speak during public comment.
Just to remind our people presenting in public comment, they have 3 minutes time limit on their presentation.
Okay. Chair Khan, I don't see anybody else that's raised their hand, but if I can ask Dr. Sonam, I think you've joined us.
I have. Can you hear me okay, Sarah?
I can. Great.
Yes. So there's nobody in the South, Sarah?
Nope, I don't see anybody else that wants to speak during public comment.
Okay, so we can move along with our agenda items. The next one is a presentation from patients about their healthcare experiences in Nevada. Sarah, you have that?
Yes, thank you so much, Chair Khan. So I don't have any patients that have signed up to speak during this segment of our meeting. However, what I would like to do is make sure that everybody who is watching and participating knows that we've created a patient portal on our website. So if you are not able to join us or feel comfortable speaking publicly, you do have an opportunity to submit your story, healthcare concerns, and experiences on our patient portal, which you could find on ppc.nv.gov. What I anticipate doing each meeting is informing everyone who of all of the feedback that we have received. This was just launched, I think, a couple weeks ago. Leslie and I worked together after our last meeting to make sure that we provided this platform for the patients of Nevada. So please share it wide and far, and let's hope that we get some feedback from some of the patients in Nevada. But at this time, we don't have anyone who has submitted testimony.
Okay, thank you. Appreciate that, Sarah. On the next item is the approval of the August 31st, 2020 minutes. I presume everybody has had a chance to look at them. If everybody has looked at them, would like to entertain a motion to approve the minutes unless somebody has some changes, corrections, modifications.
Dr. Khan, this is Mason. I'd like to make a motion to approve the minutes from our last meeting.
Great. Is there a second?
Barron, second.
Thanks, Howard. So all those, any opposed? All right, so the motion carries. Thank you, everybody. So in the opening remarks, from my point of view, basically there's not much to add. I hope today's meeting we can wrap up by 12, if not earlier, considering our last experience. And I would really like to make it a hard stop. If we haven't finished some items, we haven't finished, because I think it's not fair to everybody's time. People are making special efforts to participate in this meeting from the commissioner's point of view. So I hope we recognize that and move along accordingly. Other than that, I have nothing else to add. Coming up to the next item We have an update on reports to the to the governor and the director of the Legislative Council Bureau. Sarah, this is just an update.
Yes, thank you, Chair Khan. Commission members, I just wanted to make sure we had an opportunity to formally update not only you, but the public who is watching as well, that our next report is due at the end of this year, and I would like for you all to consider engaging with me on this report. It is something that we are statutorily obligated to submit, so I will be drafting it and responsible for submitting this report. However, I would like for you all to consider, being a part of this report. This is your report, so at a minimum, I will be drafting something very similar to our July report, which it must include at a minimum a description of any issues that we have identified as negatively impacting the quality, accessibility, or affordability of healthcare in the state, and any recommendations for legislation, regulations, or other changes to policy or budgets to address those issues. So that's our minimum threshold at this time. What I can report or add to that is the work that you've all done on August 31st. And so that's what I have now, but as you are continuing to meet to discuss today's meeting and your future meetings, would hopefully have a deeper deliberation and some consideration for other recommendations to include on that report. I anticipate having a draft ready sometime mid-December, unless we need to extend that till later December, but that's kind of my timeline. And again, I encourage full engagement from this entire commission on being a part of that report.
So two questions, Sarah, from me. One, what's the deadline statutorily that we have to, if there is one, to submit the report to the governor? And what is your timeline to submit the draft to the commissioners? So if they have any comments, opinions, or corrections on the recollections of previous meetings, then that can be submitted before your final report deadline.
So the report is due on or before January 1st of 2021. And my draft, I can adapt to making it available to whatever pleases the commission. If you, or I can make myself available between now and January 1st. I don't anticipate, I think by default, I'd like to have something drafted and ready by middle of December. So it kind of gives a couple of weeks for you all to review it and provide feedback. But if it's something that you would like to have full engagement on, would like to discuss it at the meetings formally, I can start outlining a draft for any future meeting. So I'm flexible. But by default, I would say December, the second week of December. So December 15th, if I have to throw out a hard date.
So if you are going to submit the draft by December 15th, the commissioners would have a couple of weeks to chime in on their thoughts on the report.
Sure.
All right. Okay.
If that works, I mean, we could formally agendize a draft if that is something that you would like to entertain, or we could do something a little bit more informal where I just kind of calendar December 15th, put it all on your radar, send it out to you all to review, and then ask you to give me some feedback by like no later than December, I don't know, 23rd, I would assume before the holidays. But I can certainly change and adapt that timeline to fit everyone else's schedule.
Okay. Any thoughts from any commissioner that have on that? Yes. Somebody is raising the hand, I think. Sorry. Yeah, go ahead.
Thank you, Chair. I was just curious, do you have an outline, a template? Do you know what the main chapters, sections are going to be?
I don't. I mean, I guess my outline, let me, you know what I think I should.
I just think it might expedite the process if there is somewhat of an outline and template that we can all agree on, and then filling in the components and then coming back and doing a final review.
So maybe, Sarah, if you can prepare something preliminary on the headline subjects that Teresa is recommending. These are the main topics you will be addressing in your final draft of the 15. So that way, at least they know what are the subject titles that you're planning to put it
Sure.
together.
Sure, I can do that, Teresa. So you just kind of want to see a framework, and so then that way you can see what you can add to, or sure, I can do that, and I can submit that to you guys relatively soon. So that way, if we want to give me a date, how about we plan on me sending you that outline by next Monday? Does that work for you guys? Okay, sure.
All right. Okay. Any other comments? And if not, then we can move on to the next agenda item. Hearing none, so we go on to the next, the presentation of commission ranked priorities and identified top priorities for full deliberation. So let me update everybody. Everyone got these subjects that we have discussed over a period of time by Sarah, and everybody was requested to rate their priorities and send it back to Sarah. I looked at that also, and Sarah did, and came up with the top 4 items based on the majority of people's priorities put together. And the way it turned out, based on the priorities suggested by everybody, these are the top 4 that came out as everybody's interest in pursuing for further discussion. And what I would suggest is to, in the interest of time, we can go like we do with every commissioner one at a time, and to see of these 4 priorities, in which order, if they want to still follow the order as put together, which I would think was the best way, since everybody has already had a chance to look at the subjects and put their thoughts into it. We can start discussing one at a time on this, and then go from there. So we can go with every commissioner's opinions on this so-called final analysis of the priorities to begin with, and then see where we go from there. These are items that could be discussed with the next meeting, 2 or 3 or all 4 in one meeting, hopefully, and then narrow them down further from these 4 to top 2, and then 3 and 4, and start deliberating on them one at a time. So maybe we can, it's on the screen now, as you see it all. So I would like to have every commissioner give us our thoughts. We can start with any one commissioner, any side, and maybe we can call out each commissioner's name, and they can give their thoughts, and we can go across with every commissioner's opinions.
Okay.
Sarah, you want to do that, please?
Sure. So I think what I'm going to do is kind of reverse the order that we had before, because it's nice to see you, Commissioner Bohannon, but you were missed at our last meeting, and you were a strong voice for patients in our state. And I think what we'd like to do is start with our patient advocates on the commission. So I'll start with Commissioner Bohannon.
Okay, so I'm just starting with number 1, like my feedback on it. Is that what you're asking of me, just to kind of my thoughts on it?
Yeah, and in these
Okay.
orders, obviously there are 4 items. 1, 2, 3, 4, we can discuss in that order in future, but everybody can comment on their thoughts as they give their opinion.
Yeah, so I'm strongly in support of number 1. The only thing I would add to it is that when we talk about healthcare workforce issues, that we make sure that we don't have a narrow view of healthcare workforce, and make sure to include public health workforce. I think the pandemic has really exposed how lacking we can be in our public health workforce. Obviously, we also lack providers, and there's a litany of reasons for that and issues that we have to face. But I'm definitely supportive of that. I'm just looking at these. Let's see.
So are you taking notes, Sarah, please? She wants to add public workforce, right?
Yeah, looking at it kind of as sort
that's
of how
item number 2. Yeah, that's item number 2 on the workforce. Okay.
Yeah. So did you want me just to stop with number 1 and then we'll come back to the rest of them? Or would
Yes,
you like
I
me
think if there's anything to add, we can probably do that now and briefly, so that when we come back for the next meeting, start discussing each item. If there's anything to be added that perhaps we missed in the original draft that was sent out to give the priorities.
Yeah, I mean, I think that's really of those, the last one isn't really on my list of top priorities. But the rest of them I think are fantastic. They'll definitely make an impact if we're able to address them. But yeah, I think that's really all I would have to add among those that have been addressed.
All right, thanks, Teresa. Who's next in line?
Yarleni?
Good morning. So in my opinion, the way I understood this is we have these 4 topics that it's their priority for all of the members of the commission. And we need to decide which one would be discussing further in the next few meetings. So in my opinion, we should go in further first talking about the review and examine the cost of healthcare and the primary factors impacting those costs. And then second option for me would be healthcare workforce issues in Nevada.
All right, thank you. That's the order we have.
I think that's the order we should go in.
Okay, thanks. Appreciate your input. Who's next?
Jessica?
Yeah, so I'm really excited that we're going to pursue these priorities. The first one, the review healthcare workforce. I know that there's been a lot of work that's been done on this in Nevada. And so I just really hope that we can emphasize getting a real overview of the factors that drive this and the opportunities, what's already been done, and what we can do to support it. The other thing is with Medicaid, I think that could be really interesting because that's very intertwined with workforce, right? Like really looking at the shortage of Medicaid providers that we have, and not just providing, like healthcare services and mental health services, but also I know like dental is a big issue. So those 2, I think, are actually pretty complex. And same with the third one as well, review and examine the cost of healthcare and primary factors. So I guess as a member, I just look forward to receiving as much education as we can on these issues so that we can make some strong recommendations on them.
All right, thank you. Who's the next in line?
Sean?
Sean, are you by any chance on mute?
Yeah, I just had to take myself off mute. I apologize. As I stare at the top 4, I agree completely with them. I think they're great. With respect to workforce, I know we had some discussions around licensure and reciprocity from other states that I don't believe made it into any final bill draft. But I think that if we could perhaps look into that for any kind of final report with respect to reciprocity of licensure for physicians when crossing state lines in certain instances, I think that would be something that would be worthwhile. And then I know that between UNR and UNLV medical schools and us wishing to retain those graduating students in the marketplace here, if we were able to encourage some sort of loan forgiveness or loan payment back, if they were to stay local in the state, perhaps work at federally qualified health centers, FQHCs, that would work to treat mainly Medicaid patients. However, they do treat other patients, but mainly Medicaid or uninsured. I think that would be something that might be worthwhile for us looking into. With respect to Medicaid itself, I know Suzanne is going to give us a presentation here in a little bit, but the caseloads there are increasing. I believe that the report said 1 in 4 Nevada residents currently covered through Medicaid. However, I would imagine that would continue to expand as we look out into quarter 4, and into the future. But we want to make sure that there's active participation by all providers in the Medicaid plans, as well as the plans themselves, the managed care organizations. As we think of affordability, I also know Heather's going to be talking to us a little bit around the exchange, affordability of healthcare. Want to make sure that folks know that they can go out there, get covered, that quite a few of them, a strong majority of the members of the enrollees through the exchange are covered through the advanced premium tax credit, which makes healthcare quite affordable to them. And if they aren't looking at it, they should. I know that we have an extended enrollment period this year through January 15th, but the fact that people can get covered, and oftentimes it would be for no premium in certain instances, depending upon their level. But I think that that's something that we should also continue to push and continue to make sure that the citizens of the state are educated, especially in a time like this, when many of them are going to be needing healthcare. I think that we also have to still look at just the costs in general with respect to certain bill charges from certain providers as well. But I appreciate the opportunity to share some comments.
Those are great ideas, Sean. Appreciate it. Just a couple of thoughts on the licensure part. I think we can incorporate that into the workforce, because that's sort of a workforce physicians, how it adds and improves the workforce of physicians by reciprocity of license, etc. That's perhaps could be added on that subject. And your thoughts on the Medicaid could be incorporated in the subject that is addressing the Medicaid. Does that make sense?
Yes, thank you, Mr. Chair.
Okay, thanks, Sean. Who's next?
Bobette?
Hey, can you hear me? Am I on mute?
Yep, I
Yes,
can hear you.
you're up. You're fine.
Okay, thank you. I've got to pull my screen up the right way. I agree with the priorities. I'm really glad that these top 4 priorities are something that we feel like we can turn our attention to. On the workforce, I think that I saw something that Dr. Sonam, Commissioner Sonam provided that was an outline of what was previously discussed about changes to the way licensing occurs in the boards. So I think that the board pieces of manpower are really important, and I think that that's a good addition for us to make sure we hang on to specifically where we can reform on that. And then, as you know, the other 2 I think are great issues as well. My key issue remains: what else can we be doing about really identifying cost issues and the drivers of cost and price? So I think while we've done some transparency work this session, the things that I would like to just add briefly for us to continue on are what is currently available, and we discussed that a lot in our last meeting, and it made it into the BDR, but we don't need a BDR to lift up what's currently available to monitor price. So I'd like us to do that. I'd like to get DHHS's thoughts on that. Secondly, I saw that DHHS is interested in participating in this Peterson project. I'd like us to support that and have the PPC put a letter forward supporting participation in that. And I think those 2 things would be specific things I'd like to make sure we add to our agenda. Third, I think I really appreciate that we're going to hear today about what's going on with the exchanges. I think with the Biden win, the idea of a public option added to either the exchanges or the healthcare terrain in some way is probably going to become more of a reality as an option. And I know that Commissioner Bahanan did have that early on, the review of a public option as one of our pieces. I think that is a cost solution and a price solution. So I'd like to see if there's a way for us to try to at least gather some research on that and get a snapshot of what's going on with the options for that, and have that something that the PPC has access to. Those would be my suggestions.
Okay, great. That was very helpful. Appreciate that. We're taking notes on all of these. Who's next in line?
Dr. Sonam?
Thank you, Sarah. Can you hear me okay?
I can.
Excellent. We're making it up a little bit over here technology-wise, but as long as it works. So I think that the list is great, and I appreciate Commissioner Bond's points. I think there are a couple of other things that we could add to the agenda. I'm wholly focused at the moment, given the pressures that we're having as a state around COVID with workforce issues. We are not only burning our people out, we're in for the long haul. Things are getting worse, and that's on top of a deficit that we start with every single day. So I am certainly very passionate about the workforce issues, and I think the other ones like Medicaid, and costs are as important as we look forward to the work. Thank you.
Thanks, Commissioner Sonam. Appreciate that. Who's next in line?
Dr. Peckham?
Thank you. I agree with what's been discussed up to this particular point. I would just am pretty emphatic about the importance of workforce right now. I think we're on the front edge of the next nursing shortage, if not already in it. I think the kind of fate of the GME task force seems to be uncertain, certainly its funding. And so I think we have workforce issues in the best of times, and I think they've been exposed over the last 7 or 8 months with the pandemic. So that would be kind of my plea, is to access and insurance coverage are moot if we don't have a workforce.
Thank you, Dr. Peckham. Appreciate that. Who's next?
Dr. Barron?
Yeah, so I agree with the list. 2 subheadings maybe in the list. One is with regard to workforce. Dr. Peckham mentioned the GME funding or lack thereof, and GME task force and so forth. But I have some interesting data I think that I shared with you, Sarah, that we could, as a commission, we could potentially be advocating for more of our medical student graduates to be offered GME positions that are available within our state, rather than self-selecting for people that live elsewhere to come here to train, given that we have a higher probability of retaining graduates, medical school graduates at least, that do medical school and residency in our state. And right now there's no incentive for our public medical school GME programs to take in-state graduates. And so I think that as a commission, we could potentially be driving funding for GME when it becomes available to be awarded to programs that preferentially take our graduates here. So that's one subheading under number 1. And then with regard to examining the cost of healthcare, I still feel very strongly that one of the things, as a practicing physician in our state, one of the things that drives up cost tremendously is the inability to interchange and access records from patients that are being referred elsewhere, whether it be for testing or procedures or things like that. And there's a lot of duplication of efforts and a lot of expense involved in reordering laboratory studies or imaging or things like that people don't have access to. So delving a little further into the health information exchange options that we have, what's currently available, what could be improved upon, and how we best see that working in our state could be a potential driver of improved cost to our state. So those are the 2 subheadings amongst these things that I'd like to see us work on a little bit more.
It's great, Howard. That's very helpful. And I'm sure Sarah and staff has taken good notes on all these items to incorporate as subheadings into the relevant priorities that we have outlined. Next in line.
Sorry, Mason?
Hi, good morning, Chair Khan and Commissioners. Totally agree with everyone's comments. I mean, I think we're putting it all on the table and trying to all solve a common problem. I agree with Commissioner Bohannon's comments early on about looking at the entire workforce. We had some really great data at the beginning at our first meeting, even, and looking at, I agree with Dr. Peckham that we're in the midst of a shortage. We're just not seeing the full effects of it yet. But and then around Medicaid, and I'm appreciative we have Dr. Whitley and others on the commission to be able to help us navigate that, because we know we're going to see probably more Medicaid enrollment here in the future based off of our economic conditions forecasted. So again, I agree with all the comments, and I'm glad that we're putting it on the table and look forward to the in-depth dialogue. So very supportive, and I agree. Hopefully we got some good notes here, because I'm enjoying this conversation.
Thanks, Mason. Who's next, Sarah?
I think we have Commissioner Flo Khan on the line now.
Oh, great. Okay. Flo, can you hear us? Are you on mute?
Can you hear me?
Yes, now we can.
Okay, perfect. Okay, so sorry about that. And sorry to join the conversation late. So I didn't have the ability to hear what others had said earlier. I would just, so forgive me if I kind of reiterate what others are saying. From my perspective, it looks like we're just looking at individual commissioners as to what they would like to see going forward. Is that correct?
So what we are doing is the 4 top items that were sort of put together by everybody's input that we had sent out. So you can see the top 4 items. We are looking for any additional subheadings that the commissioners may want within these 4 items or into these 4 items, if any additional subheadings need to be focused on.
Okay, great. So basically, I agree with the 4 that are up there. I would just want to kind of put out to the commission members, as we look at particularly the cost of healthcare and the primary factors impacting those costs. I think there are some good groups out there that we could look to, particularly to follow on the work that we've already done with respect to the all-payer claims database and the transparency bill that we are awaiting from the Ledge Council Bureau. And so those groups could really come in and help us as we want to proceed with those, get some additional information as to how that data could be used going forward from a policy consideration to see, to help us navigate, because there's going to be a lot of information that we get supposedly from the all claims payer database. And I think it would be really helpful for us to have some presentations to direct us, to guide us on how that data that we collect can be useful on an ongoing basis and going forward with the state. So that would be my only thing. Other than that, I would just say from the role of the PPC, I think it is good for us to have future discussion as to what we can be doing to help achieve some of the goals that the governor laid out, which is really making sure that healthcare is accessible, it's affordable to Nevadans. And then, you know, how do we as a commission continue our purpose, which is kind of in my view, kind of an oversight role to make sure that what we put forward is actually working. And then if we need to come back and look at bringing additional insight in to drive us to say, okay, we've noticed that this isn't really making a difference. How can we use the information we've collected to make a difference? And where do we see a need to make changes? So those would be my additions. But other than that, I think we're on the right track. Okay,
great. Thanks a lot. Appreciate it. So that sums up all the input on these items, and we'll incorporate the subheadings that have been suggested by various commissioners and move on to the next agenda item. We'll bring these items of the priorities in that order with additional subheadings at our next meeting to start deliberating on each item going forward. Item number 8 is presentation Nevada uninsured population and current status of health insurance enrollment numbers. So we have some people presenting. Are they here?
Sure, let's just check in. Meredith, are you here? I think you are back in the meeting.
Yes, thank you.
Okay, perfect. And Chair Khan, if you can, I think Leslie is going to go ahead and share her screen so Meredith can speak and we'll pull up the presentation.
So that's great. I hope all the presenters have understood the limitations of time on each presentation. So I would appreciate if everybody is able to honor that.
Yeah, and as a reminder, Chair Khan, I think the anticipated format for this agenda item that we talked about was allowing all 3 presenters to present their slides and then hold questions. So until the end, after the conclusion of all 3 presentations, and that way any questions can be asked by either one of the presenters.
Okay, great, thanks. So let's proceed.
Okay. Can everybody see my shared screen?
Yes, thank you so much.
Okay.
Meredith, it's your time.
Well, thank you, and good morning to everyone. Thank you to Chair Khan and to Sarah for inviting the Gwynn Center to present at this meeting of the Patient Protection Commission. We appreciate the opportunity to discuss the findings from our analysis of Nevada's uninsured population. That report is up on our website, but we've updated here today with the most recently available data. It's a lengthy presentation, but I'm going to do my best to stay within that time frame window of 15 minutes. So next slide, please. This kind of just gives an overview and an outline of how we're going to proceed today. So the first thing is why profile the uninsured, because we're going to look at some of the socioeconomic characteristics. And the idea here is that policymakers and program officials recognize that targeted interventions may help reach population subgroups that are amongst the uninsured and help to reduce their numbers. But we really can't know what those options are until we know who they are. So it's really important to take a look at these groups and break them out a bit. And then we also want to think a bit about the consequences of the uninsured. And for the purposes here, I mean, when we think about patients, that's at the individual level. So what does it mean for individuals not to have healthcare coverage? It means diminished healthcare access. That can lead to adverse health outcomes. And in the extreme, that can mean higher mortality rates. Relative to their insured counterparts, the uninsured are more likely to go without care. Medical debt is an ongoing concern for the uninsured. And then looking at a more macro view, if you wanted to kind of zoom out and think about, say, employers, poor health amongst the uninsured increases absenteeism, which in turn can affect labor productivity, business profitability, and more broadly, economic growth. Moreover, uncompensated care cost Nevada hospitals $174 million in 2016. Federal, state, and local governments, along with private entities, do help defray these costs. However, the opportunity cost of this foregone revenue is the diversion of funding away from other programs and services. Health insurance is a major determinant of healthcare access. I've yet to mention COVID-19. It's obviously an ongoing, if not more present concern than ever. And while it's not the specific focus of this presentation, I'll bring it up as relevant, but I would say this: the uninsured population in Nevada may be more vulnerable to the health impacts of COVID-19, particularly if their uninsurance status coupled with risk factors reduces their access to care. So you'll see there's the outline of how we're going to proceed. We'll talk about historical patterns of uninsurance, Nevada in national context, the geographical distribution of uninsurance in Nevada, the characteristics of the uninsured, and then the eligible, non-eligible uninsured in the state. Next slide, please. So what we're seeing here is a time series. Nevada has made gains in health insurance coverage since the full implementation of the Affordable Care Act in 2014, as the figure shows. 2020 is an estimate. Let me come back to that. But for now, let's compare the lowest uninsurance rate of the period, which was in 2018. That was 11.9%. And to that of the highest just after the Great Recession in 2012. Now, it's a difficult comparison to kind of make, primarily because of the intervention of the ACA, but it does kind of show how Nevada has trended over time. At that point, uninsurance was at 22.2%. So we've seen a 42.3% decrease from nearly 1/4 of the state population to just over 1/10. That means that the rate nearly halved. 2019 is the last year for which actual data is available. You'll observe it has a higher number of folks than in 2018, but a lower share than in that year. This is likely due to population growth of about 5.3%. We had about 157 new Nevadans come in. If more incomers were insured relative to the population, there could be offsetting effects. Interestingly, 2019 was the first year that the individual mandate was zeroed out. So we might have actually expected an increase in the rate of the uninsured. Now, the big question, of course, is what about the effects of the pandemic? We've presented a number for 2020. I can walk through that methodology in Q&A, but this is our estimate of current uninsurance. We think that the number of uninsured Nevadans has increased to 466,400 484, that would be a 15.3% share of the population, or about a 34.2 year-over-year increase. That's still below pre-ACA implementation, but it is kind of a large number in our recent state. So going from there, we also want to note that Nevada has remained above the national average, even with ACA and Medicaid expansion, something I will discuss further as we turn to the next slide, please. So this figure shows Nevada in comparative context. Again, as noted in the previous slide, Nevada's uninsurance rate in 2019 was 11.4%. The national average was 9.2%. The state with the highest rate of uninsurance was Texas at 18.4%, and the lowest was Massachusetts at 3%. But there are some really interesting points to note here. Generally, there's a loose correlation between Medicaid expansion and lower rates of uninsurance, or if we wanted to look at that another way, the highest rates of uninsurance tend to be concentrated in non-expansion states, which are those that are shaded darkly here. Wisconsin is a major exception. Of course, it covers adults up to 100% of FPL and Medicaid, but did not adopt the ACA expansion. But regardless, that correlation does not hold true for Nevada. Nevada's uninsurance rate is the 8th highest in the nation. Of the states that have implemented Medicaid expansion, only Alaska, with an uninsurance rate of 12.2%, outranks Nevada. And in fact, 7 non-expansion states have lower uninsurance rates than Nevada: Alabama, Kansas, North Carolina, South Dakota, Tennessee, and as I mentioned, Wisconsin. So comparatively speaking, Nevada still has work to do. Next slide, please. This is a county level look at uninsurance in the state. This most recent data is 2018. The rest has been 2019. What we see is that as population, so too is the uninsured population. Nevada's uninsured population is concentrated heavily in Clark County. 12.5% of Clark's residents are uninsured. That is above the state rate of 11.9% for the 2018 year. Some rural frontier counties do have higher rates of uninsurance. For example, like Pershing, they have an uninsurance rate of 14.6%, but that amounts to 685 people versus the over 265,000 in Clark. The other urban counties, Washoe and Carson City, have lower rates. Their rates are in the 10% range. So there's really no urban-rural divide. Collectively, the 14 rural frontier counties have an uninsurance rate of 10.2%. The 3 urbans, driven up by Clark, have a collective rate of 12.1%. Slightly higher in the urban areas, but not significantly so. Again, the difference is in the numbers and in Clark County. So there's less of an urban-rural divide than a Clark rest of the state divide. Next slide, please. Here we begin our demographic profile by examining age cohorts. I think what's important to know for the next several slides is the purple bars or columns versus the gray ones. Where we see higher purple ones, that's a share of the uninsured population. If they're higher than the gray, that means that they are overrepresented in the uninsured relative to their population size. And here we see that disproportionate representation in the shares of a lot of the adult population. So in the 19 to 25 cohort, 26 to 34, 35 to 44, and 45 to 54. The largest gap is in those aged 26 to 34, where more than 1/5, or they represent more than 1/5 of the uninsured, but only 13.1% of total population. Collectively, all adults, except those aged 55 to 64, account for nearly 70% of the uninsured, while representing 47.5% of the population. The disproportionate representation of young adults amongst Nevada's uninsured population may be attributed, at least in part, to the under 26 coverage rule of the ACA, where individuals can remain on their parents' health insurance policy until their 26th birthday. But other factors may play a role in this generational tendency toward uninsurance, such as financial insecurity, declining wages, and student loan debt. And that's reflected in the disproportionate share of those aged 35 to 44, who represent about 1/5 of Nevada's uninsured as well. That youth and older individuals are not disproportionately uninsured likely reflects availability of public programs such as Medicaid CHIP for the former and Medicare for the latter. Next slide, please. Looking here at the breakdown by sex, male Nevadans represent a greater share of the uninsured than their female counterparts. That's 54.1% versus 45.9%. Since we originally looked at this data, that male number is growing. Relative, of course, to their population shares, men are disproportionately uninsured. Depending on the grip of the pandemic, this may change. From Lorand, occupations and industries with higher shares of women workers lost more jobs. Some reports show that 1 in 4 women are considering leaving the workforce permanently. For our purposes, the question is the implications for uninsurance. If women have exited the labor force, continue to do so, and or do so on a permanent basis, and they were the primary employer-sponsored insurance or ESI beneficiaries, that could have a ripple effect on uninsurance rates for both women and men. So we want to keep an eye on this metric. Next slide, please. Here we're looking at the racial breakdown. So the demographic distribution of uninsurance largely corresponds with the state's population as a whole, with the exception of other race, which is highly overrepresented amongst the uninsured. I promise I will come back to this. Most groups account for the uninsured in rates that are comparable, if not less, than their overall shares of the population. There's a slight overrepresentation in the American Indian, Alaska Native population, but it's not overly disproportionate. As with the breakdown on sex, questions remain about the prospects of insurance or lack thereof for communities of color in Nevada, which were hard hit economically by COVID-19. Many individuals of color are employed in sectors disproportionately affected by the pandemic. Does that signal employment-related insurance losses? Possibly. And given that some people of color have higher risk factors, an example here would be African Americans with diabetes and higher cardiovascular mortality rates. African Americans have higher COVID-related morbidity rates as well. Uninsurance could translate into adverse health outcomes for communities of color. As promised, I said I would talk about other race. It may seem puzzling to sort of understand why a category that's somewhat uncategorized seems to be overrepresented. We don't have the numbers yet for 2019, but if you saw the numbers for 2018, you would see that 97% or 97.5 to be more accurate of those identifying as other race are Latino. And so we do want to talk about Latino uninsurance, and we will explore that further on the next slide, please. So in Nevada, Latinos represent over 1/3 of the state's population at 38% and 63.7% of its uninsured. The distribution of non-Latino white individuals is nearly a mirror image of that for Latinos. Over 1/5 of Latinos, 20.6% in Nevada, are uninsured, while just 7.2% of non-Latino white individuals are uninsured. This requires some unpacking. It is possible that some Latinos lack health insurance because they are undocumented immigrants, but we cannot infer at all that Nevada's undocumented immigrant population is disproportionately Latino, nor can we assume that all undocumented immigrants lack health insurance coverage. Nationally, less than half do. About 45% are uninsured, so about 55% are insured. Some Latinos are not citizens, but are lawfully residing in the United States, and some non-citizens do face barriers in accessing coverage. The non-citizen foreign-born, not necessarily Latino, that is, make up 9.8% of Nevada's population and 32.2% of its uninsured. So there might be something to look at there. But another possible driver is that Latinos overall in Nevada tend to be on the younger side. In Nevada, the median age of Latinos is 29.2 years, while the median age of the state population as a whole is 38.4 years. As discussed previously, it is the 26 to 34 age cohort that is most overrepresented amongst the uninsured. We should note that Latinos in Nevada have contracted COVID-19 in the greatest numbers relative to their share of the population, making the question of uninsurance an exigent matter for this population. Next slide, please. We'll run through this one a bit more briefly. Here we really see that tipping point after the middle quintile. So lower income Nevadans are concentrated more heavily amongst the uninsured than those with higher levels of income. It's actually not the lowest quintile that account for the largest proportion of the uninsured, but households in the second lowest quintile, that's the 25,000 to 49,999 range. Households in the second quintile make up a larger share of the uninsured population, 24.5%, than their representation in the state's population of 18.4%. Now, of course, a lot of this depends on household size, but this group may be the group that exceeds poverty guidelines that would make them Medicaid eligible, but have a low enough income that a marketplace offer effectively may be unaffordable. Middle income households in the 50 to 75,000 or so range comprise a fairly substantial of the uninsured as well at 23.2%. It's this middle income group where Nevada's median household income of 63,276 would be situated in the distribution. Thus, we see that overrepresentation amongst the uninsured is dominant across the low to middle income groups, but drops thereafter in the second highest and highest quintiles. Across all groups, there could be questions of affordability with respect to the marketplace, but also for workers who receive an ESI offer who may decline coverage if the employee contribution is too high or the offer is otherwise unaffordable. Next slide, please. So here we are looking at the distribution of the uninsured population by poverty level. What is nice here about the availability of this data is that it does map, at least in some degree, to thresholds from the ACA. So the below 138 would be Medicaid eligible, 138 to 399 would be where you have the marketplace benefits, and then above 400 is the phase out. There are some overlaps in the categories, and we should also note that, of course, this is just income and not programmatic criteria. But I think this gives us a loose sense that the groups in that below 138% FPL and then the 138 to 399% of the FPL are where you see the higher rates of uninsurance. If you look at, again, that middle group, marketplace offers may be technically affordable, but not actually affordable, especially now during the pandemic when difficult trade-offs must be considered with respect to household expenses such as food, transportation, and so forth. Now, again, too, as I mentioned, the eligibility for the advanced premium tax credit phases out above 400% of the FPL. So those in that group may have offers that theoretically would come up unaffordable. Note that those in poverty in general account for 20.5% of Nevada's population, but 20.4% of its uninsured. Next slide, please. And this is one that we'll conclude on. Our analysis of the demographic, social, and economic characteristics of Nevada's uninsured show that individuals and households that lack health insurance coverage are distributed across all population strata, young and old, white individuals, people of color, men and women. Uninsurance is a problem that now is an estimated near 500,000 Nevadans face daily. However, some groups are represented disproportionately amongst the uninsured. These include young adults, men, Latinos, and lower income individuals. While some Nevadans may meet the income qualifications for insurance either through Medicaid or in the marketplace, they may be disqualified for coverage or other criteria such as citizenship status. Some are eligible but face other obstacles such as language barriers. And of course, as I've mentioned a couple times, folks may qualify for coverage through offers that meet the technical definition of affordability, but are not so. In practice, rising premiums have compounded the problem. And in this context, some people assume the risk of foregoing health insurance. So, of course, to address the problem, we need a diverse mix of strategies. This table was prepared for the Gwynn Center by the Urban Institute. It disaggregates the uninsured population by eligibility to provide a broad perspective on those who may qualify for healthcare coverage but remain uninsured. It does predate the pandemic, so the numbers are a bit rough right now, but it does represent a programmatic view that could be captured with respect to triangulation of the population profile data. Nearly half of Nevada's uninsured are ineligible for the reasons identified in the table. Other than non-citizens, this is more a question of technically eligible, but not so in practice. The remainder, 55.8%, are eligible but uninsured. The Medicaid CHIP eligible and those who are marketplace tax credit eligible with family incomes at or below 200% of FPL are prime candidates for outreach and enrollment efforts, because the coverage available to them is subsidized the most. And so we would hopefully look for some opportunities there. And I think Suzanne and Heather will have a lot of insights in that regard. Thank you so much. And with that, I'll look forward to any questions any members of the commission might have.
Okay, thank you very much. Appreciate it. We have the next presenter here. As we said earlier, all questions will be held to the end of all presentations. So is it, who's the next presenter? Suzanne Bierman?
Hi,
Is
good morning.
that who's next in line, Sarah?
Yes, I think I see Administrator Bierman. I see her. And Leslie, if you can take a moment to pull up her presentation.
Yeah, just a reminder, please follow the time restraints because we have to complete our meeting by 12 noon one way or the other.
Leslie, are you there? If not, let's see. I think I can pull it up too. Hold on.
If not, we can move to the next presenter and come back to this person.
Sorry about that. Let me try again.
Do you have it? If not, I can. I think I've got it up.
I've got it.
Okay.
Okay. Can you see it?
No. Okay, let me just go ahead and pull this up. I've got it. Let's hit
I
share.
don't know why it's not coming up.
Okay, I think I've got it on my end. Is it up? Okay, great. I think we're good. Okay,
Sorry about
Administrator
that.
Bierman.
Great. Well, thank you all for inviting me this morning to talk about this important topic. And I will try to be quick, understanding that there are time constraints this morning, but just wanted to provide a quick update on Medicaid enrollment numbers. Next slide, please. So here you can see changes in Nevada Medicaid caseload for more than the past year, calendar year here, but really what's significant here are the changes since February and the kind of post-COVID effect that we've been seeing. We've seen a sharp and steady incline in Medicaid enrollment since the beginning of the COVID pandemic. As you can tell, we were staying around 645 in enrollment, pretty steady until about February or March of 2020, and then have increased up to our latest numbers of 755,763. So an increase of about 112,000 people over that time period, which is a 17.4% increase. And with that addition, Medicaid now covers about 25% or 1 in 4 of all Nevadans. Next slide, please. So here again, some of the information we just went over, the 17.4% increase since February of 2020. That brings the overall caseload since October 2019 at 16.5%. And again, this is, Medicaid is a countercyclical program, so we do typically see and expect to see increases when the economy gets worse. Medicaid enrollment increases, and you can certainly see that trend here. Next slide, please. Okay, this has just more granular information by budget category or eligibility group. You can see the changes in enrollment and would just flag that the largest increases have been in the newly eligible and parents and children categories. And this slide too does make mention of some enhanced federal matching funds that the Medicaid program has received through the Families First Coronavirus Response Act, which has actually increased the amount of federal funding that we get for certain eligibility groups by 6.2% through the end of the public health emergency. So really critical that we've gotten that enhanced funding to help absorb some of these increased costs that we're seeing associated with the increases in caseload. So just wanted to flag that here, and it does have implications for some of our enrollment trends. There are maintenance of effort requirements that have certainly contributed to our increased enrollment numbers. Next slide, please. So again here, this one just points out again that the largest growth in the Medicaid program by category is in the parents and children and newly eligible adults. And the newly eligible adults group, that's of course the Medicaid expansion group. And even without the 6.2 enhanced FMAP, that particular eligibility group is matched at 90% by the federal government. The enhanced FMAP actually doesn't apply to that particular eligibility group. But that's still the highest federal matching funds we receive for any of our eligibility groups. So that's where the majority of the growth has been. Next slide, please. Okay, this one provides information on the checkup program, which is what we call the Children's Health Insurance Program in Nevada. And here you can see that we are having declines in the checkup program. And that we also expect to see during times of economic worsening due to FPL or federal poverty level guidelines and the changes when family income changes, those children lose checkup coverage, but then gain coverage under the traditional Medicaid program due to those declining household incomes. So I just wanted to show on this slide that you can see that the vast majority of the kids that are leaving checkup are going to Medicaid, and then a much smaller percentage are no longer enrolled. Next slide, please. So again, a similar slide here just showing for CHIP to Medicaid, almost all of the recipients that are leaving, it's due to declining household incomes, and they're actually picking up eligibility in a different aid category. So just wanted to provide some additional information on kind of the transition between eligibility groups that we're seeing associated with the COVID pandemic. Next slide, please. Okay, this one I think is really interesting and is related to the Families First Coronavirus Response Act that I mentioned previously, mentioned that there are certain requirements around continued eligibility that go along with the state taking that enhanced FMAP for the Medicaid program. And actually what we're seeing in terms of our numbers going up are really due to those maintenance of effort and continuous coverage requirements under the Families First Coronavirus Response Act. And you can see that in this slide and actually the next slide where it has additional information on the medical applications. And you can see that we're not seeing an increase in the number of applications received, but instead we're not seeing redeterminations or people losing eligibility during this time due to those protections under the Family First Coronavirus Response Act. So just really wanted to point out here that the majority of the increase that we're seeing is not because of an increase in additional applications at this time. It's due to those maintenance of effort requirements that are associated with federal law. And also just want to point out that the Medicaid program historically sees its largest increases in applications during the time of the exchange's open enrollment period. So we're interested to see if that trend continues this year as well. Next slide, please. Okay, I wanted to spend just a minute highlighting this report. It was actually requested as a follow-up to the Gwen Center's fantastic report that Meredith just provided an overview on. I think that report was so interesting and full of so much great information, and really pointed out that Nevada has, for an expansion state, still quite a significant number of uninsured and remaining uninsured individuals in particular. So had the opportunity to talk about this at a national meeting, and it attracted a lot of attention and interest. And Nevada was actually selected by Princeton University's Woodrow Wilson School. They have a public policy graduate class every year that selects a state and a health policy issue to go study pretty in depth. And in 2019, culminating in this report that was published in January of 2020, this group actually came to Nevada and met with a large number of stakeholders and really dug in and looked at some of these issues around the remaining uninsured here in much greater detail, and actually published this report, which I have provided to the commission. And it provides additional recommendations on outreach and education efforts and other strategies that Nevada could employ to try to address some of the remaining uninsured. And as Meredith mentioned, certainly all of this is a little unsettled, and we're not sure what the final numbers will look like when the public health emergency is over, but certainly know that Nevada had quite a large number of uninsured and remaining uninsured pre-pandemic, and have talked a little bit about the numbers that we're seeing now, and being largely tied to some of the requirements that are associated and tied to the public health emergency period. So I think when that ends, have a better sense of how our numbers are leveling out. And I think this will continue to be a really critical and important issue for Nevada. So just wanted to highlight for the committee that there is an additional resource out there that's pretty comprehensive and has a lot of additional information and some recommendations on this issue. Okay.
We'll take we have one more presenter, so we'll take the questions after that.
Okay, great. Thank you so much.
So we have the next presentation ready.
Yes.
Heather, you're on.
Great, thank you,
Okay.
Leslie. Thank you.
Okay. Bear with me here for a minute. All right.
Thank you, everybody. Thanks, Leslie. And thanks, Meredith and Suzanne. I really appreciate all of that good information, and hearing it in this format has been helpful. For those of you who don't know, my name is Heather Korbulik. I'm the Executive Director of the Silver State Health Insurance Exchange, which is the state agency that runs and operates the Nevada Health Link. You can go to the next slide, Leslie. I just want to go over a little bit about what the exchange is up to, how things panned out for plan year 2020, what we're looking at for 21. Really briefly, I promise I will stick to the 10 minutes, challenges for 2021, and then talk about the uninsured Nevadans that are potentially eligible for Nevada or for Nevada Health Link, and the efforts that we're making as a state to contact and get in touch with them. Next slide. So for those of you who don't know, the Silver State Health Insurance Exchange is a state agency, and we run and operate Nevada Health Link. I hope that you've started to hear a lot about Nevada Health Link in the last few days. Our ad campaign really kicked off for open enrollment that started on November 1st and runs, as Sean mentioned earlier, through January 15th of this year. Our job is to connect Nevadans who are not insured by their employer, by Medicaid, or by Medicare to comprehensive health insurance. Everybody who's eligible can purchase ACA certified qualified health plans or standalone dental plans on the exchange. If they're eligible, meaning they're between 138 and 400% of the federal poverty level, they can receive subsidy assistance that helps to offset those monthly premiums. As of just this last year, as of 2020, we are a fully autonomous state-based exchange. I'm pleased to say, and many gray hairs later, that we successfully transitioned away from healthcare.gov, and we now are operating fully as a state-based exchange on NevadaHealthLink.com. We are a solely self-funded state agency, so we do not have any state general funds or any federal funds that support our operations. Next slide. Clearly, our mission is to increase the number of insured Nevadans by facilitating the purchase and sale of health insurance on Nevada HealthLink. And we can skip this slide. For 2020, we had 77,000 plus enrollments on Nevada HealthLink. 54% of them were female, 46% were male, kind of lining up with the data that Meredith was showing that predominantly females are getting insurance. And we know that they are the family caregivers that oftentimes are making decisions for the family. So we do see an increase in female, and that's been throughout the years on the exchange. Most of our enrollees are between the ages of 18 and 54, again, kind of in line with the trends that Meredith outlined. Next slide. Most of our consumers for plan year 2020 were actually enrolled in silver plans, which is good. Another 40% were in bronze. I wanted to also call out that, and something that Sean mentioned earlier too, that many of the recipients on the exchange were seeing $0 plans. And oftentimes those $0 plans are actually in the bronze category. We had over 45,000 people who took active engagement with the system and made an enrollment choice. Another 31,000 of them were passively renewed or auto-renewed. Over 80% of the folks that are on the exchange, or 4 out of every 5, have advanced premium tax credits, and then about 41% are under the 250% of the federal poverty level, which means that they get cost sharing reductions too, which helps with the payment of co-payments and deductibles. Next slide. So just a quick look at the year-over-year enrollment. We have seen a slight decline in our enrollment since the high of 2018. Lots of different factors. If you paid any attention to the Affordable Care Act over the last, 10 years, it's been nothing but drama and trauma. So we anticipate that some of that has to do with this decline in enrollment. Next slide. Just a quick look at where the bulk of the majority, or where our enrollees were for plan year 2020. Most of them clearly are in Clark County, the second largest being in Washoe. And of course, we know there are a lot more of those folks who are uninsured in all of these counties. So let's go to the next slide. The good news, I'm really happy to say that this plan year, for plan year 21, which we're currently doing enrollment for, we have 50 qualified health plans, which is nearly double what we had to offer consumers last plan year. Health Plan of Nevada, Silver Summit, and Anthem are all returning to the market, and we have 2 new carriers, Friday Health Plans, who are statewide, and then Select Health, who is in Clark County and Nye County. Of course, we have all 4 levels of metals: catastrophic, bronze, silver, and gold. And then skipping ahead, I wanted to point out that we have 21 qualified dental plans. And what's really important to know, and what we're just starting to see some real advantages as being a state-based exchange, is that you can purchase dental plans on the exchange without having to purchase a qualified health plan, which is an advantage over healthcare.gov. And this really is a good opportunity for people who are Medicare eligible, who don't maybe have a dental plan through their Medicare provider. This year, we're happy to announce that we partnered with a vision carrier called VSP. And so we are helping facilitate the sale of good, affordable vision plans. We've extended our open enrollment. Our rate increases on average were about 4.2%, but of course, anybody who is subsidy eligible, so over 80% of our consumers, don't really have any impact from that increase because the subsidies increase in turn with the increase in rates. We have 8 different navigator entities across the state, and then 5 broker grantees who have set up storefronts and who are doing online and in-person enrollment. Next slide. Lots of challenges this year. I can answer more questions if the commission has any, but I will just outline that, of course, like every other organization, COVID-19 poses its challenges. Tomorrow is a big day for the Affordable Care Act with the Supreme Court hearing the case. The election has been, of course, dramatic and interesting in terms of what happens with healthcare. A lot to be unfold over the next several months in terms of what will happen to the Affordable Care Act. We also know that unemployment rates are very high in our state. We have the federal pandemic unemployment compensation and the lost wages that have been federal add-ons to unemployment benefits that create an interesting dynamic for people who are trying to account for their income on the exchange. We also, as Suzanne outlined, are working closely with her division and the Division of Welfare and Supportive Services, because we know that many people will start to be redetermined for Medicaid on their Medicaid eligibility. And so we want to make sure we're catching people who may be falling through the cracks so that they don't fall through the cracks. And then, of course, we always have aggressively competed plans, short-term limited duration plans, health sharing ministries that market themselves as ACA certified, but are in fact not, and end up being a real problem for consumers who thought that they had a comprehensive plan. Next slide. So just thinking through the numbers and as they relate to the exchange, pre-COVID, of course, the estimate was that about 77,000 Nevadans were eligible for exchange for Nevada HealthLink products with subsidies. And we know that primarily many of them were Hispanic or Latinx between the ages of 26 and 44 years old, mostly male, and most of them were most of the uninsured population were within the realm of being eligible for subsidies. Next slide. So what is Nevada doing? Thank you again, Suzanne, for pointing out that report that you had the Woodrow Wilson School working on. That was such a helpful document and really worth the time of the commission. But what we're doing right now in open enrollment period is a robust marketing and outreach campaign that targets diverse populations, including Hispanic and Latinic populations among other ethnicities. We are really targeting right now self-employed or gig employees, making sure that they understand that these benefits are available to them. We're also looking at ads that target and outreach that targets 26 to 44-year-olds. We know that when we have a younger risk pool, that the rates actually improve for everybody on the exchange when we have a healthy risk mix. We're emphasizing the affordability and the availability of subsidies and making sure that people understand that yes, health insurance on the surface is expensive, but if you're eligible for subsidies, it can be quite affordable. We have great entities across the state who are doing grassroots outreach for us through our navigator services. We also have a really dynamic group of community organizations and stakeholders who collaborate with us and who promote the exchange on social media and out and about in their activities. And then finally, we have partnerships with and collaboration with the Division of Welfare and Supportive Services, with Medicaid, and with the Department of Employment Training and Rehabilitation. One that is in the works right now that I think may be of most interest to the Commission is that we are currently working on developing a cost allocation plan to augment our navigator services so that we can continue to do the good work through our navigators of not only enrolling Nevadans into Nevada HealthLink plans, but also onto Medicaid plans. So this is a really interesting partnership. I don't think I've seen it in any other state, and we're really excited about the possibilities and potential. Last slide, I would be remiss if I did not remind the Commission that it is open enrollment, and anything you and your organizations can do to get the word out about open enrollment is just so critically important. Please share our content. I don't think I need to say this to this group, but I will anyway. There's never been a more important time to have comprehensive health insurance. Pandemics are a very bad time to be uninsured. And with that, I will stop talking and be happy to take any questions. Thank you.
Thank you. Really appreciate it. So Sarah, we can proceed with our normal procedure to identify each commissioner one at a time to see if they have any questions for any one of the presenting personalities. So can you proceed with that, please, Sarah?
Sorry, I was on mute. Thanks so much. Let's start with Teresa.
Thank you, Sarah. Thank you, Chair, and thanks to all the presenters. This was really very useful. It's nothing surprising to me, having been in public health for a number of years and looking at these numbers. year after year. It seems like we have moved the needle a little bit, but we definitely have a lot of work to do. I'm curious, I have a number of questions and comments, but one of my questions back to the Gwynn Institute is, has there been any, have you done any deep dives into not just the uninsured, but the underinsured, and how that also impacts the costs to healthcare in our state? I mean, I think that that's one of the components. Like, you may have insurance, but it's still very unaffordable when you have high deductibles, max out of pockets, et cetera. I mean, I can tell you from my own personal experience, my max out of pocket is ridiculous. And we hit it. When you have a chronic condition, you will hit it. I'm also curious too, a question to Medicaid is, was one of the strategies automatic enrollment? If you do find yourself uninsured and you find yourself in that realm, have there been strategies or discussions about automatic enrollment? A question to Heather, I'm curious about these bronze plans and the catastrophic plans and how close they become into that realm of sort of these junk plans that you were talking about. Those concern me, coming back to this question of underinsured. And just something that I want to kind of put out to the commission is, I don't know how many of you all followed this, but insurers have become more profitable during the pandemic than ever. And that's criminal. We have Medicaid having to cut, services, cut reimbursement rates, and then we have some of our top insurers raking in record profits. I think that this is another conversation about kind of looking to the Washington model of a public option and kind of forcing some of the major insurers to offer public options on the exchanges that are, affordable to the average person. And then I'm just kind of putting this out here. I think something that we have in the North, I don't think there's anything comparable in the South, but is access to healthcare network. It's a very interesting model of how they are kind of reaching some of those uninsured. And I am curious if there's been, what kind of partnerships there are. And with that, I'll stop.
So a quick comment for our presenters and our commissioners. Please be cognizant of our time constraints with due respect to everybody. So who would take the response for these questions?
I can go first, as the first question was posed regarding underinsurance. So thank you for that question. It is an item that's definitely on our agenda. We certainly share with you the idea that is a highly salient question. We think it requires a lot more data and analytics that are not quite yet available. But one thing that I'm personally hoping is that perhaps out of the results of the SCR10 study is that we'll see some of that data shake out a little bit, but if not, we'll continue to probe. We don't have any specific information at the moment, though, on that. But thank you.
Thank you. Who's next in line? Sarah?
I think Administrator Bierman.
Yeah, sure. So I think you had some specific questions about the eligibility related recommendations in the report, and there are quite a few. I would echo Heather. I really do think it's worth a look. It's a really great and comprehensive report. But some of the things they highlighted that have also gotten traction in NRM Health Committee and other places are things like establishing a full presumptive eligibility plan. I think we could have, other states have more robust presumptive eligibility options than Nevada currently does. 12 months continuous eligibility for children in Medicaid are a couple that come immediately to mind. But the report does have like a series of short-term and long-term recommendations for things like IT systems and how some improvements on that end could help, and then a lot of recommendations around outreach and education.
Thank you. I think this is more of an observation rather than question, I think. So that should be duly noted. Next, Sarah.
I think Director Korbulik, did you want to speak?
Oh, I was just going to respond to Commissioner Bohannon's question about the bronze and catastrophic plans. Thank you for that question. So the bronze plans have a lower actuarial value than silver or gold plans, which means that when consumers choose those, they're getting a lower premium, but they're also having higher deductibles and higher costs on the back end. So yes, we are trying very hard to steer people according to what may be in their best interests. I will also just add that catastrophic plans are only available for people who are under the age of 30. So we don't see a whole big pickup on that.
Thank you. Sarah, next, please.
Okay, great. We have Yarleni.
Yes, thank you. I think Teresa did a great job of asking the questions to the presenters.
I think
would
your
like to
audio is
thank the
pretty.
presenters. It was great information.
I think we're having trouble with the audio.
Yeah, Yarleni, if I can recommend you hide your video. Hide your video and just use the audio.
I think Teresa. Okay, can you hear me better now?
Yes.
Yes.
Can you hear me?
Yes.
Okay. I have no questions at this. Teresa did a great job of asking some of my questions that I had in mind. Thank you so much.
Okay, wonderful.
Thank you. Next,
Jessica?
please.
Yeah, so I really appreciate all the presenters. I thought that was an excellent overview of, all the different insurance types and reimbursement models. I have one quick question, and it's more about access to care. Kind of what I touched on in the very beginning is, so we give everyone this insurance, but is there any data, I guess this goes to Medicaid, on how, the delay in how fast people can access care in different regions of the state? I don't know if that is being collected, but that would be a great indicator.
So who would take this question?
Suzanne Bierman is who I'm hoping.
Okay.
Yeah, happy to address that. So we do actually, on a 3-year basis, are required to conduct an access to care monitoring review plan. And those are all up on our website, have a number of different indicators around the state for different types of healthcare providers and a number of measures related to access. We actually just updated it in August and submitted it to CMS in September. So there is a pretty current version on the website and also some from 2017. So there's a little bit of historical information there on access to care, and I would be happy to share that report with the commission as well.
That would be great. And if I just have a quick clarifying question. So that access to care, would that be when someone tries to engage in care and when they get that next appointment?
It has metrics around that and just the number of providers. There are a variety of metrics that are there and they vary by provider type, but would be happy to get you a summary and the link to the more robust reports that are on our website.
Thank you so much.
Thank you. Our next commissioner.
Sean?
Thank you very much. I appreciate all the presentations. A couple of quick questions. First for Suzanne, sorry if I missed it, but today there's 756,000 is what the caseload is. Was there a projection in there for January of 21 or July of 21? Maybe I just didn't see.
We're actually still working on those. The Office of Data Analytics at HHS does the projection. So what I presented today are just all actual numbers. And we're working with the Office of Data Analytics to do projections out. A lot of things are a little bit volatile and hard to predict with the pandemic. But I think we're working to get some updated projections. But just want to clarify that all the numbers I presented today are actual, to date enrollment numbers and not projections.
Okay. And I know that one of the reasons why the number of applications was down, you mentioned, was because of redeterminations and those not happening right now. Do you know when those would start again, potentially?
Yeah, so again, that was one of the requirements of the Families First Coronavirus Response Act, which is what provided Nevada Medicaid with some additional federal funding, 6.2% enhancement in the federal funding that we received, basically requires continuous enrollment during the time of the public health emergency. I mean, there are a few caveats, but it's really like someone's enrollment right now is only closed in the case of death or moving out of state. So everybody that was on the program for the most part when the public health emergency started still is. So that is the major contributor to our increase in caseload at this point, and not as much in terms of increased applications, but we do know from national trends in history that that's not that unusual, that applications usually pick up later in the period of an economic recession. You know, people oftentimes are more worried about like unemployment benefits, food benefits, that sort of thing, and then health insurance comes a little bit later. So right now, the increases are primarily tied to those maintenance of effort requirements under the Families First Coronavirus Response Act, and will stay in place until the public health emergency ends. So currently that's planned to last at least through the first quarter of 2021, but is able to be reauthorized by the Secretary of Health and Human Services. We're not exactly sure when that's going to end at this point.
Thank you very much. One quick question for Heather as well. It's along the same line. With respect to exchange enrollments in 21, I know currently we're around 77,000. Is the expectation that we stay around that same number or increase?
I wish I had my crystal ball on this one. I think that the game and the pieces change kind of constantly. I would say that we anticipate that there will be a significant traffic during special enrollment period once we start running redeterminations with Medicaid and start seeing people fall off there. And I think throughout the next year, as we sort of see how long people are going to be unemployed and whether they're returning to their employer-sponsored coverage. So I would say, I mean, my public statement is that I think we'll remain relatively flat, but that we will see some uptick into the plan year 21 with special enrollments.
Okay. And then just so I make sure I heard you correctly too during your presentation, a consumer is able to go to Nevada HealthLink, fill out, using my words, an application, and it will direct them appropriately to the exchange or to Medicaid. So it's a one-stop shop.
Correct. Yes.
Right. Perfect. And then as we think about accessibility, I go back to what Dr. Barron said earlier and what Jessica just said too. As consumers change between employer-sponsored care and they go onto Medicaid or go onto the exchange, and they may change carriers, and they would have to then be able to track records back and forth. I think that information and investment in the health information exchange, making it easier for the physicians, the hospitals, the members themselves, being able to transmit information and their medical records a little bit easier than having to track it down, and which would then create delays, is something that we should definitely include in the final report as well. How that should be fleshed out exactly, I don't know. But I think that's well worth mentioning, especially as we think about so many people moving around during the next 6 months at least. But I appreciate the opportunity for the questions. Thank you.
Thank you. Next, Commissioner.
Okay, Bobette.
Thank you. I have a couple of questions. I appreciate this format today too. I think everyone was great. Thanks for the broadening our horizons on healthcare. I'm specifically interested in one of our 4 topics of priority that came up is quality. I'm really interested in how the exchange and Medicaid are both measuring quality, what things you look at, and how do you check not just access, but how the care is actually being received and what's going on in that. When we worked on the co-op, there wasn't great progress on the exchange on that yet, but I'm hoping that you can help educate us about what's available and maybe what's needed.
So the question is for whom, Babette?
Both. I want to hear from both what Medicaid's doing and what's going on in the exchange.
Okay. So who'll take it first?
I'll go first. Thank you for the question. So yeah, we've come a long way in determining quality measures for exchange products. And one of the things that we offer on our exchange is a pretty good side-by-side comparison. It's almost like a shopping at Amazon.com. I'd encourage everyone to go take a look at the way that it works. You can anonymously shop on Nevada Health Link and take a look at the different plans, the pricing, but also all of the benefits that are available within those plans. And this next plan year, so starting, I guess it'll be 2022, we'll be displaying a 5-star rating system or quality rating system that CMS has that compiles a bunch of different metrics on the carriers and the satisfaction of the people who are being insured through them. So those will be attached to the plans when we start open enrollment of next year. But we do have a page on Nevada Health Link that I'll be happy to follow up and share that goes through those metrics for all of our carriers right now. They're just not displayed in the plans quite yet.
I have a follow-up on that before we go to Medicaid, if you don't mind. Can you tell me if we have any nonprofit providers on the exchange at this point?
No, we do not.
Thank you. That's unfortunate.
Yeah. All right. Do you have the next commissioner online?
Oh, we have Administrator Bierman.
Yeah, I just wanted really quickly to add that we do have an annual report on quality and collect lots of information on a variety of HEDIS measures. So we can also follow up and provide that report to the.
That'd be great. Thank you.
Thank you.
Okay, Commissioner Flo, Khan.
Are you by any chance on mute, Flo? So I think we can move. We can come back to her if she's not on.
Sure, I see her on, but let's go to Dr. Sonam.
Hi, thank you, Sarah, and thank you for the presenters. Lots of information here about Medicaid and the uninsured, and certainly it's a devastating situation, likely to get worse in the midst of the pandemic and with the budget shortfall. I have two quick questions, Heather and Suzanne, if you wouldn't mind. Given how close you guys are to the data and the information, look beyond that. If you could make a recommendation to PPC about something we need to do as a state to enhance the care for people adversely affected, either uninsured or under Medicaid, what would those recommendations be? One from each of you.
Well, it depends on if we're talking about with money, because a lot of these things take money. And so I guess if I were to kind of point to a couple of other states that have done really good work in this space, I would point to states like New Jersey, who have raised the cap on the federal or the subsidies. So basically they're using state funds to assist with the subsidization of individuals who are between 400 and 600% of the federal poverty level. We know that many people have a subsidy cliff and can't afford the insurance on the exchange after that. So that's something to look at. I think, you know, as Teresa, or excuse me, Commissioner Bohannon has pointed out, there is an interesting experiment going on in Washington State with a, I'm not sure I would qualify it as a public option, but it is an experiment in kind of using a provider or a carrier to offer a state-based plan. And so I think that's an interesting thing to look at. I also think that expanding and fixing the family glitch, although that's a federal policy that needs some work, could dramatically enhance the availability of plans to families throughout our state. But in terms of what we can do as a state, I think it's always interesting to take a look at what drives costs. And where are we kind of falling short in terms of workforce, and how does that have an impact on networks? And I'll just leave that there.
Thank you.
All right, thank you. Next commissioner.
Commissioner Peckham.
Yeah, I don't have any additional questions and appreciate all of the presentations. I know I'm speaking to three very busy people, so I'll be careful how I make this request, but I think the commission would be interested over the next year if they have any refresh on the data that they presented quarter over quarter or year over year. I think it would really help inform our work. I don't know if it requires a presentation at each commission meeting, but the data is invaluable. Thank you.
Thank you, Dr. Peckham. Next, Commissioner Sarah.
Commissioner Dr. Barron.
Thanks. So thanks for the presentations again. I think they were great and really kind of hit to what we need to know. I'm trying to wrap my head around the and I realize that this is 2019 data from the Gwynn Center and probably needs to be updated, post pandemic. But judging at least from that data, if I'm understanding the information, Meredith, that you presented, that left about approximately 108,000 people that were ineligible for either Medicaid or an exchange plan with a tax credit, et cetera, whose citizenship status put them in that situation. So of the 400,000 uninsured in 2019, per your data, that approximately a little over a quarter wouldn't qualify for anything as it stands right now. That said, I was also impressed by the data that showed that it seemed like the highest purple bar in terms of uninsured fell into that middle income category that you mentioned in the FPL up to $75,000 or something like that, and that's kind of interesting, and a significant percentage of those people would qualify for a advanced premium tax credit and so forth. And so let me try and frame my question, which might be for Meredith, and might be for Heather a little bit as well. If we start to tease away the people who, at least as of 2019, would qualify for something, and leaving approximately a quarter of the population that wouldn't qualify for anything as it stood at that point in time, my question is that we've talked on the surface a little bit about public options and so forth. My question is a fewfold. One is, would a public option really, which population are we going after that is currently uninsured based upon those 2019 data? Is it that middle income category of people who for some reason don't take advantage of an advanced tax credit? And what does that do to the exchange? Does that put the exchange current plans in competition with a public option, so to speak? And then my other part of the question is, would the people who don't qualify based upon citizenship status or documentation status or whatever really go for a public option? Are we fooling ourselves? Are we really going to capture that population by providing a public option? And let me qualify my questions by saying that I'm in favor of everybody having some form of healthcare coverage. That's not the issue. The question is that what is the best way in which we can offer that to people? So I guess my questions maybe are partly for Heather and partly for Meredith.
So maybe have Heather give the response first, then we can go to Meredith.
Thanks for the questions. I will be brief. I think in terms of a public option, we are having really interesting and dynamic conversations with the SCR10 study. But one of the things that I think is a limitation in terms of states trying to develop public options on their own is the fallacy of a budget. It's very expensive, and if we don't have federal subsidies and a support, it will be really difficult to achieve. And I think that that's kind of where we've always fallen into in terms of this conversation at a state level. And then in terms of your question about the uninsured rate, I would just suggest that when we see that number of uninsured, it doesn't maybe also capture something that we were alluding to earlier, which is the underinsured. So people who are in plans that are things like health sharing ministries or short-term plans, we're not really quantifying those people in those numbers. So it is likely that some of them are insured in products that I would call skimpy at best, and are really in a position of being vulnerable for paying for something that isn't actually going to cover their needs.
Thank you. Do we have any response from Meredith?
Yes, absolutely. So I would basically underscore everything that Heather said. I do think that the SCR10 conversations are going to be interesting because we want to look at that risk mix for folks in that below 75,000 range. For example, there, we might be talking about, depending on household size, folks who do qualify for the APTC or possibly even CSRs, but maybe also, you know, they're getting those technically affordable offers or they're in the glitch. And so until we know what the risk mix is, we won't know which part of the exchange might be affected in a positive or negative way. And there could be adverse consequences to that. I mean, certainly, you know, any goal shouldn't be to drain the exchange. So the idea is, again, we really need to look at that actuarial analysis. And then with respect to the question regarding citizenship, I don't know if the idea might be that there might be a concern of take up and maybe distrust in institutions, but I think I would just point to an example out of California, which expanded healthcare benefits to undocumented immigrants between the ages of 19 and 25 through its Medi-Cal program. And so there are certainly other states that we can look to for options to explore that, to expand to as wide a variety as folks as possible.
Thank you. So have a next commissioner, Sarah.
Yep, Commissioner Van Houweling.
Hi, Chair Khan and Sarah. No questions for the group. I think they've been very well covered, but I do appreciate presentations and all the great expertise we have in the state. So great work.
Thank you. We have next commissioner.
Yeah, I think that's in conclusion. Commissioner Flo Khan had to step out for a moment, but what I will do is I will follow up with her after this meeting and see if there's any questions she's had, and then presenters, if you don't mind, I may solicit you for additional feedback, but I thank all of you for your willingness to engage with the commission and come and take time to present to us.
Thank you.
Thank you to all of you. I know you guys are extremely busy, but we really, really appreciate you presenting this excellent presentation. Very informative and educational for all of us. Thank you again.
Thank you.
So we move on to our next agenda item. We have an update on collaboration and coordination between the commission and other state entities. Sarah, what do you have? We have two items under this.
Sure. Thank you so much, Chair Khan. I will start. I'm not sure, Director Whitley, I think he may had to step out. He had an executive meeting. But what I will do is I'll open it up for the first item on the Peterson Milbank Program for Sustainable Healthcare Cost. Commissioners, I hope you've all had some time to look over the program details. As I indicated on my initial email to you, I think this is a great opportunity for the commission to support Director Whitley in his efforts to participate in this program. It's also a great opportunity for us to be mindful of our state budget and resources while you're looking at having some technical assistance examining the cost of healthcare. Director Whitley anticipates submitting a letter of intent indicating Nevada's readiness to participate. And so I think it would be advantageous of this commission to consider supporting his efforts. If you looked at some of the highlights on the program details, the state is expected to conduct some core program activities, including fostering multi-stakeholder collaboration. And if you look at our state, we are unique in having this public commission already established with the multi-stakeholder group. So I think it would complement those efforts, but definitely wanted to make sure you were aware of this. I know the public that's watching is also deeply interested in knowing the commission activities. So I wanted to make sure that they were also made aware and open up for any discussion amongst you and you know, kind of throw it out there for an opportunity to kind of collaborate with Director Whitley and our and his state agency.
So you have this for possible action. What action specifically are we looking for from this commission?
I would recommend this commission just consider discussing supporting Director Whitley in his efforts to participate, for Nevada to participate in this program.
Do we have any commissioners opposed to this proposal?
Not opposed.
So I don't hear any opposition to this. So do you want us to have a vote on this, or it looks like by consensus?
I'm okay either way. I think consensus is good with me. Is if I can express that there's no opposition within the commission, I think that's sufficient enough for Director Whitley and gives him comfort. But if you would like to do a roll call vote, I think that's also another option, and it would make it more definitive.
All right, so we
Do a
can.
motion to support whatever DHHS recommends as an appropriate role for us in this. Can we
Great.
do that?
Is there a second?
I second. Baron.
Great. So from the commissioners, anybody opposed to the motion?
Not opposed. This is Tony, not opposed, just a question. It would be helpful, certainly don't have any problems with the presentation as presented. Just wondering myself, more of a comment than anything else, if participation raises any opportunity costs for things that we won't be able to do because we're now participating in this if selected. Does anyone have any information on that?
Sarah,
I don't think so. I'm not sure. I could, I don't have a crystal ball. I'm not sure what type of recommendations or data or anything that you would, discover or deliberate or discuss. But I do know that one of the targeted activities for the state is to think about, enacted legislation, or for the governor to consider an executive order or other kind of production of memorandums of understanding, or further recommendations directly to the governor. So I think that it kind of, the program outlines some kind of core activities that's already within the jurisdiction of this commission. So I think that it would be more, in my opinion, just further deliberation or advisory in nature. So I'm not sure if it would set it up because you would be looking at data, discussing things, and then making some advisory recommendations.
Thank you.
All right, so once again, anybody opposed? If not, then this motion carries. The item number B, Sarah.
Okay, great. See the second item. I think it was with the Attorney General's office. Yeah, so this item, commissioners and members, I think in an effort to be transparent with the public and everyone who engages with us, I wanted to make sure that I followed up in the public's interest to notify them that we did host a informational meeting following our August 31st meeting with several commissioners with the Office of Attorney General to kind of talk about the overall review of healthcare related mergers and acquisitions. So there was some dialogue for those that were interested. You may recall the email that I sent out asking if you would like to participate during that meeting. We had Commissioner Jessica Flood, Commissioner Dr. Sonam, and Commissioner Bobette Bond meet with the Office of Attorney General's Consumer Protection Division, and they just gave a brief overview of their mergers and acquisition process. Also talked about the Attorney General's ability to seek assistance from DHHS in reviewing proposed mergers. The Office of Attorney General is willing to come in front of this commission formally if you guys would like to. If not, I'm more than happy to continue that dialogue or set up additional informational meetings if that is something that interests you. So I just wanted to make sure that the public was aware. Everybody knew there was a limited discussion about this at our meeting on the 31st, so there was follow-up, and there's further opportunity for continued collaboration with their office should you request that.
So is this more informational, or
Yes.
you need additional input?
I could take additional input now or in between the meetings, but really I think this for me, I wanted to make sure that everybody was aware of this collaboration, ongoing collaboration.
Does any commissioner have additional comments, or they want to continue the dialogue individually or collectively with Sarah's assistance?
Yeah.
Babette also, sorry,
Yeah,
Babette.
Sure. I don't know if we want to have everybody raise their hand or go down a roll call, but I have Commissioner
Yeah.
Bond, who is formally raised her hand.
And Jessica, I saw Jessica raise her hand first, if she wants to go first.
Oh, no, go for it, Babette. Thanks.
I think, I thought it was really interesting to have them give us their sort of perspective on mergers and acquisitions. I think the takeaways for me, and I'm really interested in the other commissioners who were able to participate, what they got out of it. I think they would, they really don't see anything going on that we discussed inside some of our proposed legislation for transparency about private equity and the impact of private equity on the healthcare system and the growth of private equity. They don't see it by sector and they don't see it by company. And they are interested in it. That was one of the things that I got out of it. They're also under-resourced to take on any kind of work that we would find ability to expand their role. They would need additional resources for that. But I think they saw that as their only barrier, and they were very interested in what could be done to gain more insight and, you know, some vision into how the market's changing because of both consolidation and mergers and private equity enter the market, the impact that has on the community and the state. They were all, I thought they were very positive about they'd like to be partners on this. I think the only barrier they had was, you know, there's resources involved and they don't have resources to do very much, but they saw the need. That was my takeaway.
Thanks, Jessica.
Yeah, you know, going off of what Babette said, it was great to see that type of collaboration and them really wanting to try to, you know, join forces and being able to have more transparency. Like she said, I think like much of Nevada, you know, they don't have enough resources to really obtain the data that we need to make good decisions. So I thought that was a good point. But I just stepping back overall in terms of process, I really appreciated being able to participate in a deep dive and get more detailed information on these complex issues. So, you know, I urge other commissioners to be a part of these. And I hope that there's more opportunities for this in the future because it made me at least have a little more understanding about what we're talking about.
So thank you, Jessica. So Sarah, maybe what we could do is if any other commissioners need more insight, we can probably set up another opportunity for them to let everybody know, and then they can have additional opportunity to dialogue more and come to some understanding of what their thoughts might be.
Absolutely. And I really appreciate your engagement, Commissioner Flood. And I agree with you. I thought it was very informative and it's something that I would be more than happy to continue to facilitate. And so not only with the Attorney General's office, but any other state agency or anyone that I can help facilitate that type of dialogue or collaboration. I know it might not be in the best interest of everybody's time to have formal presentations at every single meeting. And so these really provide another alternative to those who are interested in hosting, you know, asking questions and having kind of that back and forth and informational. And then what I would do is for any of those future meetings or collaborations, I would then put them on the agenda for our next meeting. So that way the public is aware of these collaboration efforts, and then also to give a quick briefing to the commissioners who did not participate.
And just a quick follow-up comment. I just wanted to say that I really like what Dr. Sonam did earlier in the meeting, asking the experts like what their recommendations are. I feel like there's more opportunities for that in those types of meetings.
Right.
Thanks. Babette, you had something to add?
Yes, thank you for letting me talk again. I think that there was enough interest from them. I would like to see us do two things. I would like them to do what Jessica just said. I think that's a great idea from Commissioner Flood. What, given where they are now, would they recommend as next steps that would be supportive of this goal of understanding what's going on in the markets better? And number two, can we do some work, or can someone do some work to see what does happen in other states, where we might get some best practices that other states are using to try to see if we're ahead or behind or in the middle of this issue of measuring industry impact.
Thanks. Anybody else have any specific comments, or if you can share with Sarah if you need to have additional information on briefings?
Dr. Khan, I raised my hand. I just
sorry, I
just
didn't see Sarah.
Yeah,
I didn't see you on the screen. Sorry about that.
Sorry. So my question is, since I wasn't able to break away and attend that particular meeting, were there minutes taken, and can that be distributed to the other commissioners so that we can all be informed as to what the conversation was? And going forward, I think that it sounds like there's enough interest amongst the commission, at least those that were able to attend that meeting, that maybe we should have an agendized item going forward to bring them in and have them present to the whole group, what they can do. And maybe part of it can be what was asked earlier, which is could we get some information on what other states' processes are and how they go about this? Because remember, this all started with talking about the transparency BDR and trying to figure out whether there was really any need to go above and beyond what the AG's office currently is capable of doing. What I'm kind of hearing from those that could attend was that there is some need to investigate that further, but I would just be interested in seeing some minutes and also participating in a good discussion maybe at our next agendized meeting.
All right.
Hey, Dr. Khan, this is Tony.
Yes, Tony.
Thank you, Dr. Khan, Chair Khan. I had the opportunity as well to join with Commissioners Flood and Bond, and thought that the meeting was really good. It did seem as though at some point, my only 2 cents on this were, it did seem as though the Attorney General's office was a little bit perplexed about why we were there. Certainly highlighted the limitations that they had to go further in analysis, and were unsure particularly about the role that the PPC might play in that. Those were my takeaways. I think the points that were just made by Howard are really important. Any of these meetings that go on offline, I think we should, to the extent that they contain and are representing the PPC, having those minutes available to all commissioners is really important, so the tenor of the conversation is clear. The Attorney General's office did highlight the importance of confidentiality for many of the activities that they oversee, and were raised as a potential concern for engaging the PPC further. That was my takeaway, but that doesn't mean that there's not ways we can work together. And so I think having them come to a meeting where all commissioners can participate is helpful, and we should continue down that path.
Thank you. So if I hear everybody who was on it and they were not on it is perhaps have the desire to have them come and have a presentation, that way they will have time to go over what areas are confidential that they cannot share, and they can be prepared to share what they can share as an agenda item for our next meeting. Is that what everybody thinks is their desire?
I would say not just what they can share, but what they would propose would be a good, a meaningful role in this effort to understand the industry.
I agree. So in a comprehensive way, like you said, the goal, etc. And there are areas they cannot share. They should let us know. Sorry, this is an area we could not share. So that seems like a good moving forward opportunity. Sarah, could you take note for a presentation at the next meeting?
Sure,
so
I can reach out. I'm more than happy to do a follow-up and reach out. I know that they expressed their desire to continue the dialogue and willingness to collaborate with this commission. And I will circle back with the commission to see what their availability is.
Okay, great. Thank you. So moving along, the next item on the agenda, status update on commission's bill draft request. Sarah, you have an update?
Sure. Update is that it's still in the legislative process. We do not have language at this time, and so we are waiting for Legislative Council to conclude their work and submit a draft back for technical review and official filing before our deadline.
All right. Any specific comments on this? This is more of an FYI for us, since there will be no progress yet on that from the Legislative Council Bureau. If none, we can go to our standing agenda items. Item A for possible action, recommendations for commission activities and/or report to the governor and the director of the Legislative Council Bureau. Sarah, could you elaborate this for the commissioners?
Yeah, sure. Thank you, Chair Khan. So, commissioners, the intent of this agenda item and making it a standing agenda item for all the future meetings is really to provide you an opportunity to make recommendations for future commission activities and additional recommendations for our reports. As I indicated earlier in our meeting, we have an obligation to submit a report twice a year, every 6 months, and our next one is coming up to be submitted on or before January 1st of 2021. So I think the intent is to just allow you an opportunity to make a formal recommendation for consideration of either commission activities and/or items on those reports. And so I'm not sure if anybody has anything at this time, but I think that's the intent. Hi, Commissioner Flood has raised her hand.
Thank you. So yeah, I think we're on a good track in terms of having some identified top priorities, which it would make sense for those priorities to end up in the report. And, Chair Khan, you were talking about us being able to kind of dig deeper into these priorities. I was just looking at that report that they were talking about on the Silver State Solutions expanding Medicaid access. And there are recommendations in here. So I just hope that we can dig a little deeper in. Sometimes it feels like this commission, we get like a little bit of information and then we don't actually make the recommendations. So I would hope that maybe we could review recommendations from the experts, see if they fit within the commission priorities, et cetera, moving forward.
All right. Good idea, start. Babette, I see your hand.
Similarly, let me just clarify. I think that Commissioner Flood is asking about the SCR study. Is that or is that separate?
Yeah, the Silver State Solutions expanding Medicaid access in Nevada.
That came out of the SCR 10 last session.
Yeah, the Woodrow Wilson School looks like it developed it. That's
Sarah, can you verify that's the SCR work going on to the SCR 10 study that came out of the last session? I think it's the same thing, but we're using different words. So if it's not, can you also add the SCR 10 recommendations so that we see those, and just so that we're understanding exactly where they landed? I would like to suggest that. And then the second one I think would be helpful for us to see is what came out of the drug price study that Senator Kinsella led last summer.
So Sarah, you can take note for these suggestions when we go into deep diving some of our priorities, starting with the next meeting.
Okay.
All right, thank
So
you.
just for clarity purposes, we've got the SCR 10, the drug study, the Silver State Exchange report that you referenced, Commissioner Flood, and the AG's office.
I don't think mine was the Silver State Exchange report. It's Silver State Solutions. So Suzanne.
I'm sorry. You're right. Silver State. Okay. Right. Sorry. And we'll confirm that that's not the same thing as the SCR 10. Okay. I think we're good so far. And Commissioner Bohannon has her hand raised.
Yeah. It looks like Heather.
Oh, sorry. Commissioner Bohannon, you're on mute.
Sorry, yeah, I was just seeing the chat from Heather and she's saying it's not the same thing. So maybe she could speak to it.
And I didn't think so, because I think the SCR 10 report is still being worked on, and they anticipate releasing that next month, is my understanding, but I wasn't sure if I missed that.
All right.
I do think it'd be nice to have a standing agenda item to kind of continuously update on this report that we are in charge of. And to present kind of where we're at with each one, each moving forward. And then also it would be nice to, before our next meeting, to kind of, I think, figure out what our next agenda will be. If we can kind of incorporate that into our work here during our meetings. It may not happen in this meeting, but as we go, just so that we're kind of all on the same
So we
page.
have that in item C.
Great.
So if it's okay, I'll bring that up to item instead of possible action for future meetings. Before we go to future meetings, why don't we discuss potential agenda items for next meeting? So I think in this context, I would like to go in order with each commissioner that may have suggestions for agenda items. Could we do that, please, Sarah?
Okay, sure. Let's start with Commissioner Bohannon.
Okay, so I have a couple things that I think are interesting. I don't necessarily have presenters. I might lean on other commissioners that are a little bit more on the ground, but you know, we talked a lot about what the insurance, the uninsured looks like now, and kind of we got the kind of high level view of what that looks like. The next step is to really understand how uninsured, like the uninsured population actually impacts our costs. If there's any way to actually know when somebody walks through a hospital door or a provider's door or whatever, what that actual cost then, you know, becomes and how that's impacting us. I think it's interesting. I don't know how we landed all this way, but we did not rank the COVID as one of our top priorities, which is kind of interesting. I think we probably all have different reasons, but that's definitely going to impact. There's a heartbreaking story in the Reno Gazette Journal about a family, the whole entire family who was impacted by the pandemic, and the parents didn't have insurance and they're just holding their breath for those hospital bills to come in. So I think it'd be interesting to hear a little bit more about that. And I mentioned briefly about Access to Healthcare Network. They're kind of, if people aren't familiar with it, it's kind of a unique way to deal with the uninsured. So it might be interesting to hear from them. I know Dr. Peckham has some connections with them. So thank you.
All right, thank you. Who's the next in line, Sarah?
Commissioner Yarlini Roadugan.
Yes. Can you hear me well?
Yes.
Okay. So I think for the next meeting, I would like to talk, following the thought of Commissioner Bohannon, more about the drivers for the cost of healthcare, especially now dealing with the pandemic and how it's affecting the patients, especially those patients that don't have health insurance because they lost their jobs, and how is that affecting the cost for the rest of us?
All right, that's a good suggestion. Could you maybe shut off the video? I guess that helps for Sarah's suggestion earlier.
Yeah, sorry, we weren't able to hear you clearly in the last minute.
Okay, I don't know how far you heard, but my suggestion was just going more in depth into the drivers for healthcare cost.
Yeah,
okay.
we got that earlier. Great, appreciate it. Next commissioner, please.
Commissioner Flood.
Yeah, I mean, going off of what I said earlier, we have these top priorities. It seems like those priorities would track into the report, and it would be great to actually discuss recommendations for the report. So I hope that we don't get too spread out, you know, across the priorities for the next 2 months, and we can be intentional on maybe attacking each topic one at a time. So I don't have any more specific requests other than that, and to look at this report that Suzanne Bierman brought up. It seems like that would be pertinent to the follow-up for the presentations that we had today.
Sure.
If I may remind the commissioners, we have those 4 priorities already, and will obviously be following through those priorities at our next meetings, and they could be pretty, exhaustive if we take one agenda item at a time. So whatever your suggestions might be for additional items other than those 4 we already have addressed at length, then we would be happy to entertain those. So who's the next commissioner, Sarah?
Commissioner Shaner.
Yeah, I think just an update on the report that we're going to submit, opportunity to review it, provide feedback. As we are in open enrollment year for Medicaid and, the exchange, any updates that we could get on caseloads and changes that have happened there, so we know where citizens are falling out. And then oral arguments are tomorrow in front of the Supreme Court with respect to the ACA. If there's any update that we can get from anybody, I don't know if that's the AG, as to what was said, what might happen next, depending upon either way the Supreme Court decides to go and when that decision might be rendered. Just so we have an update, would be great.
All right, thanks. Next commissioner on this list.
Hey, Commissioner Bond.
I think that we have plenty going on, and I just want to clarify, I can't understand exactly, Chair Khan, if you're saying because we have our 4 priorities, they don't need to be part of our agendas, or if you're saying what I think Commissioner Flood was saying, which is we should make sure under each of those 4 priorities, we understand enough about what we're recommending or what we want to recommend inside those walls, which is what I want to do.
Yes, 2 thoughts. You're absolutely right. My thought was we already have 4 items outlined, and there could be additional things into those priorities that come to your mind we can add, because we have already addressed them at length earlier in our meeting, how to expand on those individual priorities, what presentations will help us on those priorities. But other than the highlights of those priorities, are there any additional items for future down the road that we want to add, unless someone wants to add something else into those 4 priorities? Does that answer your question?
Yes, I think everything we've talked about today fits into one of those 4 priorities.
Yeah.
Maybe we can organize our work that way, and that would be helpful.
Yeah, that's absolutely right. Next commissioner, may have anything else to add?
Okay, Commissioner Flo Khan. So I see you speaking, but we don't hear you. Nope.
How about now?
Yes.
Okay. I was just saying, I think we do have a lot already to look at. One of the things I would just add is under the healthcare transparency or the cost factor bullet or priority, there is a group, I think I've sent some information to you already, Sarah, that we can revisit, but it's on the value consortium. And I think it could help us kind of identify cost drivers within the system. And I think that could help influence us as information that we might need on a going forward basis to better understand costs within the system and where we could potentially make some changes that could really have an impact on providing high value care, but reducing costs. So I think that group would be, they're doing a lot of work based on, and I feel like I'm a dog with a bone, but on the all claims payer database issue. And so I think it's driving us, it could provide us some really helpful information on driving us to where we need to be moving
Could I
forward.
ask who that is?
All right.
Can I ask who that consortium is before we decide to hear from them?
Yeah, I mean, I'll send all the information to Sarah. It's a group, it's an academic group. It's, I can't remember right off the top of my head where they're out of. It's one of the universities back east. It's well known. Their work is being used in other states. And so we'll get you all the information.
Yeah, and thank you so much, Commissioner. I don't recall what consortium you're referencing.
Yeah.
And
Why don't I suggest that we take this offline, maybe later on you can submit all that information to Sarah.
Sounds good.
And she can distribute it to all of us, whatever the information is.
Okay,
so
great.
Sarah, to the next commissioner.
Okay, let's go to Commissioner Dr. Sonam.
Thank you, Sarah. I agree with the 4 priorities that were set up. And I'm wondering if we should have or start to slate some presentations, particularly on the workforce issues. We heard some great presentations today on the issues of cost and insurance. I'd love to really dive in a little bit more to some of those workforce issues. There are some recommendations we could contemplate as direct action items from the PPC. In addition, the only other thing I would see for an agenda is, to the degree it's available at that time, is LCB feedback on the BDRs.
All right, thank you very much. Commissioner Sonam, who else is on the list now?
Commissioner Dr. Peckham.
I don't really have anything to add that's already been said. I would say to Sean's suggestion about the Supreme Court hearing, somebody at Boyd Law School at UNLV's got to, they've got to have folks there, I would presume, who could speak to that and provide us an update if I.
All right, thank you. Next, Commissioner.
Commissioner Dr. Barron?
Yeah, so a couple things on, again, under the 4 priorities, not creating another one. One thing would be, I think we talked about it earlier, is having the AG's office do a presentation to the whole group regarding what they're capable of and what collaborations could potentially the PPC could have with them. That would be under probably under our sort of transparency questions. I still think it would be worthwhile to under cost hear something from somebody who knows about the health information exchange, the current status, and things that could be improved upon. That would be helpful, I think, for the commission to hear. And then in addition, we have a legislative session coming up in which BDRs are being filed currently, and it would be helpful to agendize any BDRs that have anything to do with the PPC in them, so that we as a PPC know what's being discussed or what's being proposed by legislators. Insofar as those things may not be fleshed out in terms of their language in the next 3 weeks, let's say, but sometime in the next month or two they will, and it would be important for the PPC, I think, to know what's being discussed in the legislature.
All right, that's a good suggestion.
I have a question, Chair Khan. Dr. Barron, when you reference any potential bill draft requests related to the PPC, are you talking about explicitly the PPC's role, or you're talking about healthcare related items, or anything that's within the scope of the commission's review?
Yes.
The latter. Okay. Okay.
Right. So I think all of the above, but I'm not talking about our 2 BDRs that are in LCB right now. I'm talking about anything that comes from outside of the PPC that either impacts the PPC's role or has something directly having to do with what our agendized items, the things that we've made top priorities. If it would, for example, if somebody's proposing a bill to look at cost of healthcare, it would be kind of interesting to know, what they have in mind, and so that we don't duplicate efforts, or that we, can join our efforts with what the legislator in question is bringing forth. So I just think that having a kind of a running tabulation of what's going on with legislative proposals for this commission that are related to our agendized items would be helpful.
Sure, I can try to navigate that, Chair Khan, if you don't mind. I'd like to just speak upon that, because I really want to make sure we set realistic expectations on that type of dialogue. And with the bill draft requests that are reported, their description is very vague. And so oftentimes we will not be able to see exactly what is being proposed until the bills are introduced. However, what I can do is try to create a running list of legislative measures that I think may warrant being on the radar of the commission. And then as that language is put out publicly, or as I can glean any information that I can through either conversations with specific legislators or those who are requesting it and inform the commission, we can take it that way. But I just don't want there to be an expectation that there will be an opportunity to have kind of robust dialogue or deliberation given those parameters.
I have just a really quick follow-up, if I could just go on that.
I think let's be brief. Yeah, coming close to our time. Yeah.
Yeah, I think this is important. So Assemblywoman Carlton has a bill draft for the Patient Protection Commission revising provisions. I just think it'd be interesting to know what she intends for our body. So I just thought on Commissioner Barron's point.
All right, thanks. I think Babette has her hand up.
Yeah, I have 2 things to respond to Dr. Barron. I don't think it's realistic to expect an Assemblywoman or a senator to come and tell us what they're putting in their bills. I just think that that's putting everybody in a really uncomfortable position. They don't drop that language until March for a reason. And I think that they have, I think that would be true of any bill that comes up. The reasons they're so vague and as they want them to be as they're putting together strategy with their different caucuses. So I just don't want the commission to put any legislator in an uncomfortable position on any bill. I just think that we are really, I think it's just really not very professional of us and not realistic about the way the process works. And I feel like we should not assume that we have that role. We don't oversee them. So I feel strongly about that issue as a member of the commission and how we interact with the legislature on any level. I think if the governor's office who appointed us wants to do that, then they should come and do that. But I don't think that we should expect the legislators to come tell us their strategy for the legislative session.
Okay, I think.
Can I finish? Let me just make my other point.
Go ahead. Sorry.
Dr. Khan. On Dr. Barron's point about the health information exchange, I feel similarly. I think the health information exchange staff and board members and people involved in it have made sure that that issue has been brought to this commission in 4 or 5 different ways. I would really like, if we still need more on that, to have it come from DHHS, which is responsible for health information exchange technology and work in the state, instead of the actual health information, the private sector health information exchange that is not subject to public meeting laws and not subject to our governance.
So my thought on to summarize is, the way I understand is that if there are any bills being debated in the legislature, once they are submitted to the legislature, bills that perhaps we may have some input or information on those, FYI, that this particular bill is now submitted, and this is the context of it, it may or may not be impacting what we are doing. So probably it seems like an FYI, not the delivery of the actual bill into the legislature. That's the way I understand. Not while they're going over the language or drafting. That's not our role, obviously.
Yeah,
So we should move on to those, the commissioners who have not been able to give their opinion yet. Let's complete the list.
Sure, and Chair Khan, if I can, with the discussion or deliberation on potential bill drafts, I mean, what I can do is say what I committed to earlier is, create a list of some of those items that might be out there just for your information. But to Commissioner Bond's point, I think it is, important that we set realistic expectations on that type of dialogue, because I'm not sure that you're able to have the robust discussion that you would like to regarding those measures, given the limited information that may be available to us. And then also knowing, what is within the jurisdiction of this commission. This, by and large, is an advisory commission. So even if you wanted to have a discussion, we can ask, but that doesn't mean that any legislator or any state agency would be willing to even engage or have that type of collaboration. So I would just encourage this commission to make sure that when you are discussing recommendations or commission activities, that you do keep that in mind.
All right, thank you. Let's go, please, if you don't mind, finish the other commissioners who have not had a chance to chime in, and then I can come back to those who may still have some questions.
Okay.
So who else is not opined yet?
Our remaining commissioner is Commissioner Van Halling.
No further real comments. I do agree that we had really good presentations aligned with our priorities around transparency, the Medicaid products. I do agree with Dr. Sloan and Dr. Barron. If we can get a little bit more further down the road for emerging issues on the true cost and what's driving that for everyone. And then also a little bit more discussion around workforce. And I do agree with Commissioner Bond's comments related to the political process, if you will. And I certainly think there'll be opportunities for us to sit in person and testify on those items. But I agree, she knows better than any that that's probably not going to happen. But I think we need to keep tabs on it and have discussions on how it does impact. So I think that needs to be a standing item, Mr. Chair, on not only the Patient Protections Commissions, but other BDRs that do have implications for Nevadans. So that's all my comments, sir.
All right, thank you, Commissioner. Who else is not opined yet?
That concludes the first round.
So I think for the next few minutes, if anybody has any additional comments, would be recognized. So that before we move to the next agenda item, is there any additional thoughts that somebody had a hand up earlier that I said, let's finish the list first? Yeah, go ahead. Is it Teresa? Yes.
It is, yeah. So I may have missed it because the conversation was I was missing some parts and not, but just to kind of go back to the conversation between everyone, will we be supporting legislation if we see it fit within our priorities? I mean, not asking anybody to come and testify to us, but that we are watching and monitoring what's happening in the upcoming session, and that we do see that, I mean, outside of our BDRs, but we do see there's legislation forward that we feel collectively does align with our mission. Will we be kind of supporting that in any sort of formal fashion? I don't know that we've had that conversation. If we have, I've missed it. I apologize.
Right.
So, go ahead. Jessica, go ahead.
Thanks. Commissioner Bonahan, that's exactly what I was thinking, is that sometimes there's opportunities for collaboration. I don't think that we would want some explicit presentation of legislation, but if there's a way that we could support, legislation that aligns with our priorities, that would seem to make sense.
Bobette, you had your hand up.
Thank you, Dr. Khan. I appreciate it. I understand that goal, and I don't know why I've decided I'm the advocate for the legislators at this point, but I think the concern I have about that is we're going to have two issues. One is, do we individually support bills that we believe work in the best interest of our goals? Absolutely. But I don't think we do that on behalf of the Patient Protection Commission, because they could change. We could be liking a bill as it was introduced and not liking it by the time it's done. And it's very difficult at that point to have the Patient Protection Commission stamp on anything that we end up not being able to roll back and not thinking it's what we wanted and not being able to support. So my past experience in commissions is, if we have our individual advocacy programs, we're going to go out and advocate as an individual with the organization we work for. But I don't think the Patient Protection Commission itself has an advocacy role in these bills, because we can't control them. And we can't speak for the commission.
And Chairman, if I can add to that, I do want to just remind the commission that we are subject to open meeting law. The legislature is not subject to open meeting law. So to Commissioner Bond's point, they move fast, they move quickly, things change. And given the structure of this commission, it doesn't appear to be, the intent was not to allow for that type of legislative engagement, given the commission's, makeup. I think, if I can say, and Attorney Ott, you may help me out here, but I just want to make sure that everybody is aware that, we are subject to open meeting law. So if a hearing, and let me just throw out a kind of a hypothetical scenario, if there was a hearing on a bill in which this commission felt compelled to testify on or advocate for, one, we may have the ability to know that in advance, but given the fact that the legislature is not subject to open meeting law, they can decide to call a meeting to order on that Monday morning. The commission is subject to open meeting law. So if I'm told that a hearing is set, we don't have enough time to formally post an agenda and then collect this group to opine on the desire to testify or not testify as a collective body. So given that restriction, this commission is just not designed to be actively participating in that legislative process.
Do we need any additional input? That seems to be self-explanatory, what Sarah just said. Greg, do you have any thoughts?
Just to echo what Sarah says briefly, other commissions that I've been involved with generally handle this by getting updates on legislation at regular meetings, but not really involving themselves in the day-to-day grind of the litigation, because the paces are different. The legislature just moves too quick for these commissions to normally have the sort of role that I think some people would like them to have.
All right, so that sort of sums it up, I guess. Did we hear from every commissioner? Nobody was missed, Sarah?
No, I don't believe so. And I don't see anybody raising their hand now, but if. on the sidebar.
All right.
So I think we're okay.
Yes, we move along. We go back to the original item B, presentation for with where were we? Sorry. We
I think
discussed
Chair
the-
Khan, we're on the future meeting dates discussion.
Yeah, that's right. That's right. We are on item D as in David.
Mhm.
Future. I think that's tough to decide in a meeting, but perhaps as we have done before, you can send out some meeting date options and see which ones most of us are available. The only question I would have is how soon would the commission like to have the next meeting so we can throw out some dates to everybody to narrow down everybody's availability. So the question is, with the holidays coming, obviously anything has to be after Thanksgiving. And certainly if meetings to be held, it has to be decently before the Christmas holiday season. So if my suggestion would be, we can have some dates early December or so, we can send it out to everybody as these options available, and then everybody can chime in. Does that make sense?
And Chair Khan, if I can remind you that we do have November 30th, I think on everybody's calendar right now is the next tentative date. I don't know if you want to open the discussion to modify that or cancel it or change that date, but I think we have told the commission that to hold.
Right. So I think everybody had that information, right? Okay. All right. So any other thoughts on future meetings? I think at that, if we convene around that meeting, we can then talk about the next meetings after the Christmas, New Year time. All right. So that makes sense, seems to everybody. The next item, I think, is public comment. Anybody up in the north, Sarah?
Sure, let me just pause for a moment and ask any one of our attendees. We've got a handful. If you would like to speak during public comment at this time, please take a moment to raise your hand and we will.
And I would remind the people to have 3 minutes limitation. If you have any presentations, the limit is 3 minutes.
And it's *9 if you're on the phone to raise your hand. You just want to press *9.
Are we having issues with this?
Nope, I'm just giving them a little bit of time to see if anybody has, would like to speak. We have a handful of attendees, more than a handful. I don't see anybody. It looks like we have no public comment.
How about in the south?
Yeah, it's virtual, so I'm not sure if I'm able to differentiate between where they are physically,
Okay.
but I don't have anybody indicating that they'd like to speak.
Okay, if there are no public comments, then I think we move to the next agenda item that everybody is desperately hoping to address is the adjournment.
I'll make a motion to adjourn, Mr. Chair. This is Mason.
Mason, and there's a second.
Second.
Bobby, thanks. Anybody opposed? No, so the motion carries. Thank you very much.
Thank you, guys.
I really appreciate it. This was a very exhaustive deliberation for future direction of this commission's discussion. So we have now focused on what items we'll be discussing in the upcoming fourth. So that's a major development. So let's convene next time and hopefully keep our time that we did today. Thanks a million to everybody for their participation. Take care.
Thank you. Good job, Sarah.
Bye-bye.
Bye.
Bye.